Actually, it's unique. Actually, to put so much effort into this. No, I don't think anybody else has put so much effort into this. It's very much closely related to epilepsy surgery.
Yes.
No other branch may benefit as much as this intrinsic understanding of brain anatomy rather than skull base and rest of it.
Yeah, yeah.
Epilepsy surgery.
Only probably glioma, deep-seated tumors,
Yeah,
and
yeah.
Neuro-oncology.
Yeah.
I think epilepsy surgery sessions meetings should always have an anatomy talk.
No, sir, to tell you the truth, I have not seen any, but with this understanding, I know exactly what is to be cut by just understanding.
I understand that.
Yeah.
Because the real correlate, no? The real correlate comes in the mind of the surgeon. And to really develop a correlate, a deep understanding of anatomy will be beneficial. Physiology, of course, but anatomy may dominate the picture.
Yeah.
We can start in 2 minutes time, I think.
What anatomy you talked there, Avida?
The skull base anatomy. So anterior skull base, middle cranial fossa, and tomorrow morning posterior fossa.
Oh, the entire skull base. Okay.
Skull base, yeah. Actually, it's good for us. You know, every time you do it, you see something new. Every time you see the picture, you think, oh, you missed this last time, you know.
How often do you do a dissection? How many a month?
White fiber, I do maybe at least once a month.
Okay.
Skull base, I don't have the time to go to anatomy. White fiber is easy because I have the brain with me.
Okay.
Yeah.
You will do it at in your lab there.
Yeah,
or?
yeah.
Have you set up a lab at home?
No. I have.
You have.
But I'm going to get kicked out now. So.
Good evening to all of you.
Sir.
Hi.
Sir is so prompt.
For Avida, there is no difference between work and home. Huh?
No, I'll get kicked out now. It's that formalin smell has come.
Oh,
I'll have to move the specimen now.
Yeah. Hydrogen peroxide is, I think, a new thing. I don't know.
No, spirit. You can put little spirit in water and that's good enough.
Yeah. Ravi, how are you?
I'm good, Bhaskar. How you have blurred your entire background, Bhaskar?
That option is there.
It's an option.
Blurring option is there.
No, I'm actually in a hotel room.
Okay, sir.
Now time is 4, sir. We can start.
Okay.
Ravi is so knowledgeable. Yeah.
Okay. Good morning. Good afternoon, everybody. Today we will be having our webinar, or maybe our first epilepsy surgery webinar of this series, on our topic of today is temporal lobe epilepsy. And if you see of all the focal epilepsy syndromes, temporal lobe epilepsy may be the most important one and most likely to become refractory. If you are having any degree of anatomical changes on a scan in the form of a sclerosis, 90% of the time, the patient is likely to be refractory. And if you say which is the most technically rewarding and the most difficult and most commonly done epilepsy surgery, it is nothing but mesial temporal surgery for temporal lobe, particularly surgery for mesial temporal sclerosis. And there is some form of this can surprise many people. Many would think that it is hemispheric surgery or maybe other disconnections, which is practically more difficult. Actually, the temporal lobe surgery is done so safely and so frequently because the surgeons are so used to it. And the entire epilepsy surgery foundation starts from temporal lobe surgery. And it is from this surgical entity that a surgeon builds into disconnecting or removing different areas of the brain. The anatomy of the temporal lobe is perhaps the most complex. And I must admit that after any temporal lobe surgery, I'm more anxious than when I'm doing a vascular surgery. When you remove portions of the amygdala very close to the perforators of the anterior choroidal, you always have a fear in your mind that this patient is going to have a hemiplegia. So let me first introduce my co-chairs, Dr. Kodiswaran. He's professor of neurosurgery, and he's in the webinar committee of NSI. So I'm not going for a detailed introduction of Kodiswaran. He's one of the most promising young heads of departments. He's in Hillpark Medical College, Chennai, and he's also working in private sector in Apollo Medical College. He has several initiatives in academic field. My second co-chair is Dr. Suchanda. Suchanda is head of the department in ISAMS. Her fields of interest are epilepsy surgery, pediatric surgery, and vascular surgery. She's also American Association of Neurosurgeons visiting fellow. She's also has a visiting fellowship in pediatric neurosurgery in Israel as well as in Canada. She has membership in several international organizations related to epilepsy as well as related to pediatric neurosurgery. She's in the International Society of Pediatric Surgery, ISP and Bylaws Committee chairman. She's also the co-chair of the Asian Australian Society of Pediatric Neurosurgery. She's convener for women in neurosurgery in India of the committee of the Neurological Society of India. She's the executive committee member of the Indian Society of Pediatric Neurosurgery. She's also a member of the Cerebrovascular Society of India, as well as the Telangana Epilepsy Education Research Academy president. Let me call Sujanda to start the proceedings.
Thank you, sir. Thank you, sir, for this introduction. And again, I was also last time there in this time doing another webinar. And today again is my pleasure and the opportunity to get the opportunity to be a part of this thing, which is very close to my heart. Thanks to Professor Matthews only, who has taught me how to do an epilepsy surgery. And I would like to say here that when I was in Canada and I wanted to learn epilepsy, they said me, why did you come here for? Go to Sri Chitra and learn. And that's how I ended up learning from him. So that is how the reputation of Sri Chitra goes. And with that, we will have start. The first lecture will be by, I don't see Dr. Ravish.
Ravish is there. Ravish is...
Yeah. So we have our first speaker, who is Dr. Ravish R. Kenny, and he is an epileptologist, and he works in Aster Hospital in Bangalore, and he's did his MBBS from Goa, and then internal medicine from Andhra Pradesh, and then DM from Sri Chitra Trivandrum, followed by his epilepsy fellowship there, and then now working as in Aster Hospital, Bangalore, and Aster Calicut. So he's also an American Academy of Neurology International Scholarship awardee in 2019, and received the Outstanding Reviewer Certificate from Neurology India in 2019. And he has many publications, and he has established many epilepsy centers, Comprehensive Epilepsy Center in Andhra Pradesh, and as well as in Bangalore and Calicut. So as we understand, his main interest is epilepsy and comprehensive epilepsy program. So over to you, Dr. Ravish, and we are all here to listen to you today.
Am I audible and visible?
Yes, yes.
Yes. Good evening, everyone. At the outset, I thank Matthew sir for this opportunity, and I thank NSI for this opportunity. And good evening to my teachers, Matthew sir and George sir. So I'm talking about briefly about temporal epilepsy, the pathophysiology, clinical feature, and diagnosis. So temporal lobe epilepsy, as Matthew sir already told, is the basically one of the most common epilepsy, and roughly it accounts for about 40% of adult epilepsies. So we can say that roughly about 2/3 of the people who are surgically amenable, they are basically having temporal epilepsies. So basically, as we are all aware, there are two types of temporal epilepsy syndromes which are recognized, mainly mesial temporal, which is the most frequent, and lateral or neocortical temporal, which is the other type. So mesial temporal epilepsy is the most common type, and typically it has antecedents, which is the one of the A's. Typically, it can be right from parental insult to CNS infection in childhood, febrile seizures, head injury, and sometimes there can be even genetic and family history of epilepsy can be there. So the most common among these is febrile seizures. Up to 60% of patients with MTS have prior febrile seizures in the childhood. Typically, the seizure starts by the end of first or second decade. It may start with a CPS. Typically, sometimes it may be a simple partial as well or generalized. Then usually what we see that the patient remains seizure free for a variable period, mainly typically 1 to 2 decades. Typically, this time usually the medicines are stopped typically, and then we see that they started having seizures in the long term, which fail to be controlled despite restarting the medicine which has been priorly working them for them. So it can be a lesional, which can have a MRI abnormality, or non-lesional. The lesional commonest one is hippocampal sclerosis. There can be other lesions like a tumor, like ganglioglioma DNX. It can be a cavernoma or some cortical malformation. Sometimes it may be a post-traumatic or the infectious causes for gliosis. So hippocampal sclerosis is the most common cause, and it's a combination of atrophy and astrogliosis we see in the hippocampus, amygdala, parahippocampus, and also in entorhinal cortex. And it affects the various sectors of the hippocampus to various degrees based on which the classification of the IL has been done. So if you look at pathophysiology, it is a vicious cycle which self-propagates over and over again for epilepsy to occur. So there's an underlying predisposition which can vary from genetic to infection, etc., which results in the void of the blood-brain barrier, and it results in the release of certain neurotransmitters over time. This, along with uncontrolled inflammation, astrocytic activation, and microglial activation and lymphocytic infiltration, this vicious cycle, when repeats over time, tends to have a self-propagating mechanism, and it leads in the long term to the disease. So the initial event which is there, if it is well controlled, usually consequences are not there. But if the initial insult is not repaired, it leads to certain alterations in the brain parenchyma as a result of the various mechanisms which I have discussed above, mainly blood-brain barrier breakdown, and also neuronal hypersensitivity, other than that plasticity, reorganization in circuitry, various things happen. So as a result of this, in the long term, sometimes seizures can happen. And apart from seizures, because they can also have other issues like cognitive and behavioral issues, which are also very common in patients who have temporal epilepsy. And in some patients, it can be controlled, basically, which we see initially, and then the medicine is withdrawn. That is the time typically we say that seizures usually start recurring again. And in the long term, despite use of the drug, they become resistant. So hippocampal microanatomy, I'll be just highlighting because of classification. So as we all know, there are 4 sectors, CA1 to CA4, and also we have dentate gyrus, which is there. Apart from that, the fimbria and alveus. So the ILE classification is based on this hippocampal involvement. So the most vulnerable damage is in the CA1, followed by CA3 and CA4. CA2 pyramidal dentate gyrus are typically more resistant. Sometimes there can be involvement of the dentate gyrus and granular dispersion, which predisposes to early seizure onset in temporal epilepsy and even cerebral epilepticus in various stages of disease. So if we look at ILE classification, it's based on the degree of neuronal loss, 0 being no neuronal loss, 1 being moderate, and 2 being severe neuronal loss. So in typically ILE type, type 1, the CA1 and CA4 both are involved. And apart from the other also involvement may be there, but CA1 and CA4 are the more dominantly involved sectors in this. Type 2, the CA1 is the dominant involvement here. And type 3, we see the CA4 predominant neuron involvement. These are 3 types of ILA. And type 4 usually is a microscopic, but we don't sometimes find histopathological evidence. MRI based, but no histopathological evidence we find. So typically, eyelid type 1 is the most common type, and which typically febrile seizures usually are seen, and they have good outcomes. Whereas other data for remaining things like eyelid type 2 and type 4 basically some is limited. But some studies have shown that the outcome is suboptimal. So type 1 is the best outcomes among all. So etiology, basically, apart from that, sometimes we find that we have secondary MTS, what we call, where the other pathology is there, which in turn results in the hippocampal damage, like a cortical dyslamination, it can be gliosis or DNETs or cavernoma, etc. So in contrast to mesial temporal, pneumocortical epilepsy has a different profile, and here the typical antecedents are less common. And sometimes these patients can have genetic mutation as well. This is important to consider before considering a surgical option. So there can be LGI1 gene which is responsible. They typically have auditory aura. So if you look at clinical features, the most important difference between the hippocampal, the types of TLE, there's a mesial and neocortical. The most frequent among these is mesial. The typical antecedents, what we say, are more common in mesial temporal. Typically, it is early onset, whereas this neocortical starts later into the life. And typically, when you see the clinical features, this abdominal aura, olfactory aura, gustatory aura, and staring look, which is late into the onset, basically is typical of mesial temporal, where early staring look with the psychic aura like deja vu, jamais vu, auditory aura, these are more common in neocortical epilepsies, and vertiginous also. And generalized seizures basically are rare and common in mesial temporal, where we see more generalized seizures in neocortical epilepsy. And duration of seizures usually is more prolonged in a mesial temporal, which is less prolonged. And EEG typically is showing the typical patterns which we see in the mesial neocortical. Most common cause is hypocampal sclerosis, where non-lesional, sometimes it can be cortical malformation in neocortical. So typically the 4 auras which we see in mesial temporal epilepsy are antecedents, then 4 A's, antecedent, aura, automatism, and amnesia. And sometimes we may have aphasia if it's a dominant hemispheric involvement. So typically, as I discussed earlier, we have a staring loop, then oral automatisms, along with the autonomic phenomena like pupillary dilatation, constriction, hyperventilation. Sometimes they have goosebumps, etc. And contrary distal stunning posturing with ipsilateral head aversion is commonly seen. So abdominal aura, as I described, is the most common. Apart from that, you can have olfactory aura. Typically, the people have uncinate feet, and when you look at apart from the localization, whether it's neocortical, mesial, also lateralization also is very important. So automatism typically is ipsilateral, eye blinks are ipsilateral, dystonic posturing is contralateral, and when it comes to the dominance, speech arrest is seen in dominant hemisphere, speech preservation is seen in non-dominant hemisphere, and post-ictal aphasia is in dominant hemisphere. And motor manifestation, what we see typically is a contradistorting posturing. Early head deviation is ipsilateral, but the forced head deviation with the eye deviation and facial deviation is contralateral. And when sometimes the patient have a propagation to the basal ganglia and the SMA region, we have a contralateral extended arm, so that the fencing posturing can be seen. And when you look at right and left, typically ictal anesis is seen in right temporal seizures and ictal urinary urge right temporal, where piloerection is more common in left temporal seizures. This can vary from person to person. Most in general, this is what we see. When neocortical, typically I describe, they have the psychic aura like a deja vu or jamais vu, and apart from that, they can have vertiginous aura, and they have a early clonic jerk and early contralateral clonic jerk and early generalization. This is very commonly seen in neocortical epilepsies. So when it comes to the workup of this epilepsies, basically most time and foremost is the EEG and epilepsy protocol MRI. And then in patients who are uncontrolled, we go to a phase 1 and phase 2 evaluation. Phase 1, where in the sense we do apart from the MRI, we do sometimes in cases we do a PET scan or a SPECT scan. And we are neuropsychological testing to assess the patient memory, and VADA testing also in memory function and also language sometimes. And when the data is not very clear, we do an invasive monitoring where we can do a subdural or a grid or a depth electrode placement. So typically surface EEG most of times is less sensitive. It's important to have a sleep record. So ideally we tell patients to sleep deprived the previous night. So typically we see that the spikes in the mesial temporal are more of a intertemporal, whereas they are neocortical, they are more of posterior temporal. But sometimes the EEG is not useful. So in such cases, we do a video EEG, especially when we take a surgical decision. So typically findings which you see in video EEG, the commonest finding which we see in typical mesial temporal is the tilde. It stands for this typical temporal intermittent rhythmic delta activity, which is a very prototype feature of mesial temporal epilepsy. And apart from that, we see the spike and sharp discharges. These are more of mesial temporal and anterotemporal in the case of medial temporal, and more of posterior temporal and in neocortical epilepsies. An ictal pattern, typically we have the monomorphic theta rhythm, which I show in the subsequent slides in a medial temporal epilepsies, whereas it's a slower delta rhythm, typically neocortical. Sometimes it may be diffuse onset with attenuation. This can be seen either of them. Internal recording, sometimes it is used when the data is not very clear. Typically, when seizures are lateralized but not localized, or a discrepancy between the seizure location and data available on the imaging, and also for eloquent area lesions. So typically, MRI, which we see is we see at the various sequences, and typically, classically, we see a hippocampal atrophy with a flare hyperintensity with ipsilateral temporal dilatation. Also, that can be mammillary body atrophy, which we see. And apart from that, we sometimes have neocortical changes secondary to long-standing epilepsy. Also, it may be secondary to underlying dysplasia as well. So after that, in some patients, we do a PET scan, which is then which looks at the glucose uptake. Typically, the area which is damaged because recurrent seizures is hypermetabolic. But what we see is that sometimes it may extend beyond temporal lobe in other areas as well, like a frontal, parietal, as well as thalamus, subciliary side. PET mainly has a lateralizing and localizing value. We are told because of the broad hypermetabolic sometimes it be seen. And sometimes with possible, this is a typical PET which is hypermetabolic, you can see, and MTS on the same side. Sometimes when if possible, we do a SPECT scan. It helps in localizing. More sensitivity is very high compared to the PET scan. It's cumbersome because you need a technician to be there with the patient when there's seizure, and also video monitoring to be done. So typically what we see is that we do a SPECT at two phases. And we do ictal SPECT, interictal SPECT. So in this one, you can see the interictal phase, the left temporal pole is all hypometabolic, hyperperfused. And when we give an injection during a seizure, it's a hyperperfused. And then sometimes we subtract both of them and we have an area which lights up. So this can sometimes be superimposed on the MRI, where we do a SysCom, where we subtract the data and then we superimpose the MRI, and it actually picks up in MRI which is possibly seizures on it. So apart from that, we do sometimes tests like VARA test. Nowadays is not commonly done. Priorly, they used to do mainly for memory function. But nowadays, with the advent of neuropsychology and functional MRIs and resting MRI and all, this is not commonly done for temporal epilepsies. And functional MRI, I told, mainly for looking at the language, especially on the left side, when we do, sometimes when we plan to do a little wider section, we can do a language mapping in the functional MRI, which can be a resting or task-based fMRI. And neuropsychology testing is mandatory still. This still is a gold standard, especially when we are dealing with the patients who are having a very high IQ and very intellectually good. So basically, what commonly we see is that if dominant temporal epilepsy, we find a verbal memory deficits. Where non-dominant, we find a visual memory deficits. And sometimes the memory can be based on normal. Then we have to counsel the patient that possibly deficits may occur, or we have to sometimes plan for minimally invasive surgeries. So just to illustrate some few cases, this just to show what I discussed so far. First of all, the 26-year-old male typically had febrile seizures. He had aura of fear. He had premonition. Then he had irrelevant speech. So looking at antecedents, febrile seizures, it points to a probably a typical aura of fear, typicals to a probably a temporal seizure, and mostly major temporal because there is no generalization, and typically had a irrelevant speech. So that points to a non-dominant hemispheric involvement, and also partiality and awareness again points to a non-hemispheric involvement. This was typical seizure one's classical one at recorded at home. So you can see here he himself is telling to the wife to record the video. You can see the left hand is postured here. He's able to talk to his daughter as well. And then during the video, again the same event was recorded. Again, he has the seizure, he feels the seizure is coming. He's again very clearly is able to communicate to the attenders he's going to get seizure. And even he tells them to take a video and show a thumbs up. So you can see very clear cut, there's a right-sided build up in the temporal chains on the same time. So commonly this is mistaken for a non-epileptic event because this is happening in office, he's showing a thumbs up and all, but this is typically non-dominant hemisphere. Sometimes the awareness can be retained. That's the important thing note from this case. So this MRI typically showed this classical right major temporal sclerosis. So this was a prototype right temporal seizure. Second was a 35-year-old female, sorry. She was having seizures from 25 years of age. She had deja vu aura and a fear, and she had early aversion to the left side and the behavior arrest. So deja vu, again, there is no antecedent here. And deja vu, again, point to more of a neocortical kind of a picture. With the early head aversion to the opposite side, again with the chronic jerks pointing to a neocortical picture. This was a seizure during the recording what she had. So clearly she says that so she can report the deja vu feeling here. And during the seizure, again, video EG recording, we see a right temporal buildup. She has a seizure, some automatisms with the right hand. She actually was trying to call the technician. And then the right temporal seizure propagates. And then there's a head rotation to left side. And then this right side, we see automatisms. So it is important to note that right side, the speech can be very well preserved. So this patient had a very rare cause, temporal encephalocele, you can very clearly see here. So this was there. Along with that, she had a neocortical changes as well. Third was a typical female with a 27 female with seizures from 18 years, auditory aura, then Wadian's aura. This again point to a neocortical epilepsy, and she had frequent generalized seizures. So indicating the right side aversion indicates left neocortical epilepsy. This was seizure recorded during the video EG. You can see the temporal seizure starting on left side. Following which we can see there is a facial deviation, head deviation to right side. And then there is asymmetrical posturing, tonic posturing of both the upper limb, asymmetrical extension of the right, and then followed by left, and generalization. Our MRI showed MTS. Along with that, you can see there are some neocortical changes as well. And PET showed a left temporal hypometabolism. So this was a temporal neocortical epilepsy. Just the last one case. So in some patients, as I told, sometimes we need to phase 2 monitoring as well. So this was a patient actually who had 3 pathologies. You can see there was a MTS, there was a occipital gliosis, and PET showed hypometabolism right as well. A scalp EG showed a seizure from the right side, but the MTS was left side. So it was data were discordant, and also that occipital gliosis, whether it's contributory or not, was not certain. So we did an image recording, bilateral hippocampal depth placement, and also occipital depth electrode placement. We placed orthogonal, sorry, we placed vertical electrodes from occipital region, and this was a seizure recording during the invasive monitoring. Typically, she has behavior change, automatism, chewing automatisms. The right is free, then she has bimanual automatisms. Nose wiping on the right side. EG showed very clear-cut right onset. So this patient had seizures from the right side. So the MTS was more on the left side. So high chance of getting memory issues. We deferred and we underwent venous therapy. Just to conclude, just about some apart from that, sometimes we have to also take into picture that temporal plus epilepsy from various areas, which sometimes can mimic a temporal seizure. Sometimes results in a failed epilepsy surgery if we do a age. It can be from the lobe, it can be from the neocortex, from the insula, and also occipital region as well. Just to show some cases, it's typically they have nocturnal seizures, no aura, very brief seizures like this child. And we can see in our child ping, we have a left frontal, some beta activity, and left frontal seizure. You can see very clear cut left frontal beta is there. So that starts earlier. Sorry. Later into the phase, the temporal propagation occurs. So that time he has this chewing automatisms, etc. So you can see the right hand, that desktop imagery looks like temporal, but the concept is very clearly frontal. His MRI showed a FCD in the orbitofrontal region, and a PET showed a very concurrent hypometabolic area. So this and things should not be missed out. So if you do a ATL, this will fail. And other than typically, everyone knows this insular cases. This lady had typical insular seizure. Well, you can see
Dr.
she
Ravi,
has this typical throat constricting feeling.
Dr. Ravish, if you can just wind it up because.
Yeah, I just wind up. Yeah. So this one, sometimes you can see a very clear-cut insular cavernoma. With that, I end my presentation, and thank you for listening.
Thank you, Dr. Ravish, and it was wonderful to hear all this MTS, what we see very regularly in an epilepsy surgery program. And I think you please follow the chat box for answering any of the questions which will be raised there. And at the end, during the panel discussion, I think you can answer all the questions. Over to you, Dr. Matthew.
Let me call upon Dr. Kodisharan to introduce the next speaker, that is Abida. Kodisharan?
1 minute. I'm coming. Good evening, everyone.
Yeah.
Now I'm happy to introduce my friend Dr. Abida Shah. We used to call her Indian Rotan because one of the best anatomists in Indian continent, and she used to demonstrate all her anatomical work in 3D. So we used to enjoy in our conferences. She's known to everyone. She's a fellow in endovascular surgery, and currently she's associate professor Seth GS Medical College and KM Hospital, Mumbai, and consultant neurosurgeon KM Soumya Hospital Research Center and Apollo Hospital, Navy, Mumbai. She got multiple awards and honors: Asian Congress of Neurological Surgeons, an Indian Society of Neuro-Oncology Award, and Vesalius Award, and ANS Annual Meeting Award, and Spring 2014 Women in Neurosurgery Award. She had multiple publications. Her H index is 39 and citations around 8,000, and I index is around 120. And she's editor of multiple journals, and recently she took over NSI case report journal. Welcome, Abida. It's over to you.
Thank you, Kodishwaran, for this introduction, and thank you for this invitation for this webinar. Can you see my screen?
Yes, yes.
Yeah.
Okay. So we've just heard an interesting lecture by my previous speaker, and we heard various terminologies that he used: the fimbria, the dentate gyrus, whether that is the origin of the seizures, the piriform cortex, the entorhinal cortex. So I will show you the anatomy of all these regions, and let's try to make some sense out of it. So when the primitive amphibians left the oceans, they became reptiles, and they developed a big olfactory nerve, because olfaction was the main sense of, it gave sense of danger to the animal, and it also helped in the smell of food. So this became a very important sense, and that's why they had long olfactory nerves. When the mammals came into the picture, there are two organs that developed. One was the olfaction, and one was the amygdala and the hippocampus. So both these structures developed on the head of the brainstem, or on either side of the thalamus, and then they came to their position as the evolution grew, as I will show you. So initially, these two structures were there. So the archicortex was the amygdala and the hippocampus. The paleocortex was the olfactory or the piriform cortex. And these are actually the limbic structures, which is made up of primitive cortex. Around these two structures developed a medial cortical ring, or the paralimbic structures, and the insula. The paralimbic structures are the parahippocampal gyrus and the cingulate gyrus. And ahead of this, lateral to this, developed the isocortex, which was of 6 organized layers. And this, as we know, is the neocortex. So the reason why epilepsy is so common in this mesial temporal region is, you can see in this image, there are so many different varieties of cortices that are meeting in this region. And so it is natural for this area to develop epilepsy. So as I said earlier, this is the brainstem. This is the head of the brainstem, or sitting on top of the brainstem is the thalamus. So on either side of the thalamus on one side developed the hippocampus and amygdala, and on the medial lateral side developed the olfactory cortex. So as we evolved and the cerebral hemispheres grew, the whole structure turned down in this C-shaped manner to have the current position of the hippocampus and the amygdala, which came to lie here in the mesial temporal region, and the olfactory cortex came to lie here along with the entorhinal region, came to lie in this mediobasal brain region that we see in further images. So this is the area which is where we get the mesial temporal lobe epilepsy. And let's see the anatomy of this region. Another important thing is the hippocampus and the fornix, they were actually in this region. So once this hippocampus came down here, it was invaded by fibers of the corpus callosum. So some part of the hippocampus remained, you can have it as a remnant above the corpus callosum, and we will see that as the inducium griseum. So as the hippocampus turned and came down, it was invaded by corpus callosal fibers, and some part of the hippocampus that remains here and connects to the subcallosal region, that is the supracallosal part of the limbic system, and we will see that as the inducium griseum. So this is the medial temporal brain, as we are all familiar with. We know these structures, the corpus callosum, the anterior commissure, here the fornix, the choroidal fissure, the region of the third ventricle. This is the aqueduct, this is the pineal gland. And here you see hidden in very close relation to the cerebral peduncle is the mesial temporal brain. Looking at it from the inferior aspect, you see this is the cerebral peduncle, and this region that we know here is the mesial temporal brain, and that is the area of interest in this presentation. So if you see this is the uncus. Now the anterior part of the uncus corresponds to the amygdala. The posterior part of the uncus corresponds to the head of the hippocampus. So this is an important landmark, and you can see that it closely relates here to the cerebral peduncle. Vascular relation is the posterior cerebral artery, as we will see in the further images. This part of the uncus is actually corresponds to the entorhinal region. So as also the basal forebrain here region is the piriform cortex or the olfactory region also. So looking at the inferior part of the temporal lobe, so this is the inferior temporal gyrus. This is the temporo-occipital sulcus. This is the fusiform gyrus. This is the collateral sulcus. Now, if you see this sulcus, the temporo-occipital sulcus generally curves here medially. It very frequently has this curve. So the whole fusiform gyrus appears as if it is pointing medially and pointing towards the cerebral peduncle. This region, this sulcus that you see here is the rhinal sulcus. So the rhinal sulcus separates this primitive cortex from the neocortex. So this is one of the second sulci to appear during development. Now you can see another image where you can see the close relation of the uncus to the cerebral peduncle. And this structure that you see here is the parahippocampal gyrus. The parahippocampal gyrus medially will continue with the cingulate gyrus and the lingual gyrus, as I will show you on the medial aspect of the hemisphere. So now you can see a part of the uncus has been removed here, and you can start seeing the head of the hippocampus in this region. And more anteriorly, if I remove this gray matter, I will see the amygdala in this region. Now, this is the fiber relation on the base of the brain. So you see this is the internal capsule continuing here as the cerebral peduncle and going down into the midbrain, pons, and the brainstem. There are many other fibers that come into play, and they are all important to understand for epilepsy surgery. These are some important things that also you must remember. So if you see this is the olfactory nerve, it is dividing into the medial and the lateral olfactory striae. It does this just above the anterior perforated substance, and then it turns laterally. So this lateral olfactory striae actually connects here with the uncus. You see this region? And this whole region here is the piriform cortex or the entorhinal region. It ends here in the region of the semilunar gyrus of the uncus. Now, the vascular relations, the most important one is the anterior choroidal artery, which is a branch of the internal carotid artery, and it comes down in the anterior aspect of the temporal horn here. And where it is enters, it divides the hippocampus, parts of the hippocampus into the head and the body. And that entry into the temporal horn is known as the inferior choroidal point. Here you see the posterior cerebral artery also giving out the lateral posterior choroidal artery and that supplies the posterior aspect of the temporal horn and the occipital horn. So here you can see a part, the choroid plexus and the beginning of the hippocampal head in this region. Now let's dissect step by step from down to understand the fiber relations of the medial temporal region. So this is an inferior dissection. So what we have done first is I've removed the gray matter of the uncus. You see this white fibers that are coming into picture here. They're thin lines here, and this is the radiation of the cingulum. So the cingulum actually has, the cingulum is covered by the cingulate gyrus, and it curves around the corpus callosum and ends here in the region of the entorhinal area. And it is known, the ending here is known as the radiation of the cingulum. Now you can see these fibers a little more clearly. Just beneath this radiation of the cingulum is the ependyma of the temporal horn. So now you can see that I have peeled off some fibers are still there, and you can start seeing this bluish hue of the ependyma of the temporal horn. Now I've removed this radiation of the cingulum and the ependyma. And what do you see? You see the whole hippocampus. So this is the head of the hippocampus. This is the body of the hippocampus. And turning here is the tail of the hippocampus. So you see these serrations on the head of the hippocampus that give it its peculiar appearance and the name of seahorse because of its shape. So this is the pes hippocampi. Now you see this structure here, this gray structure here is the amygdala. Now, if you imagine that there was the gray matter of the uncus here, this was the anterior part of the uncus, which is continuing here is the amygdala. And this is the posterior part of the uncus, which is continuing here as the head of the hippocampus. So now this is the choroid plexus that is running in the choroidal fissure. Now I've deflected this hippocampus here. It is downstairs. Now you can just see the choroid fissure, choroid plexus. So this is the part of the branch of the anterior choroidal artery as it is entering into the temporal horn at the inferior choroidal point. Now I've also reflected the choroid plexus downwards, and you see these fibers that are coming into view here. So if you see this, this is the optic tract ending here into the lateral geniculate body. From the lateral geniculate body, these fibers come out and they go anteriorly and turn laterally to run into the temporal horn lateral wall. So they form, initially they run in the roof and later they run in the lateral wall of the temporal horn. And this is the Mayer's loop of the optic radiations. Now you can see them more nicely. So this is the lateral geniculate body. And you see these fibers that are coming and turning laterally into the lateral aspect of the temporal horn. So this is a view from the inferior aspect. So here I have not removed the fibers. Here I have removed the radiation of the cingulum. Here you can see there are some fibers of the radiation of the cingulum still left. This is the hippocampus. This is the temporal horn. This is the region of the amygdala. This is the head of the hippocampus. This is the uncus. Now you see how closely it is related here in this region. So to this, I've removed the cerebral peduncle. Now another thing that you can see here. So the hippocampus, when it turns here, and becomes the tail of the hippocampus, and above it the fornix will turn. Both the fornices will meet here, and if you see this layer here, this is the hippocampal commissure or the saltarium. So this just beneath the splenium. Sometimes you cannot separate the splenium from the hippocampal commissure, but on this inferior aspect you can see this, both the sides, the fornices are meeting here in the region of the hippocampal commissure. So now this is another image to show you the Mayer's loop as it is coming here, and you can see them beautifully turning like this and going in the lateral aspect of the temporal horn. So you see the optic nerve, the chiasm, the optic tract going to the lateral geniculate body and then turning here. So surgically, this is one of the most important relations that we have to understand when you are doing mesial temporal lobe surgery. Now again, coming back, so we saw the dissection from the inferior aspect. Now coming back to the medial part of the medial temporal lobe. So as I told you here, the parahippocampal gyrus. So this is the parahippocampal gyrus. It continues here above as the cingulate gyrus and also posteriorly into the occipital lobe as the lingual gyrus. So both of these gyri contribute to the formation of the parahippocampal gyrus. Here you can see that this is the cingulate gyrus lies below the cingulate sulcus and above the callosal sulcus, and it turns all around the corpus callosum. Now, the interesting thing about this parahippocampus. So you just try to imagine and be with me. So the parahippocampus turns medially like this. This edge here where it turns, that is the subiculum. So this is a triangular area, and this is actually forming the floor of the ambient cistern. And this is the region. It is called subiculum because subiculum means edge. So this is the subiculum. It also turns upon itself anteriorly. And the parahippocampus turning anteriorly gives rise to the uncus here. So now this is a closer view of the uncus. So as I showed you on the inferior surface, I told you there is a connection between the basal forebrain that goes all the way to the anterior aspect of the uncus. So this is that connection, and this is the anterior aspect of the uncus or the cellular gyrus. It is separated here. So the anterior part is more voluminous, and it is separated from this part of the uncus, that is the ambient gyrus, by this uncal sulcus. This is an impression of the tentorium in the region of the parahippocampal gyrus, dividing it into the uncus above and the parahippocampus below. Here you can see the temporal stem, which I will again show you later. So here you see the anterior choroidal artery entering into this region and going into the temporal horn. Now coming back here, as I had shown you the termination of the cingulum in the entorhinal area, this is the beginning of the cingulum, which begins here in the subcallosal region, goes above the corpus callosum, comes all the way here, turns in this region. This is the isthmus of the cingulum, and ends here as the radiation of the cingulum. It also gives branches to the, it also gives connections to the neocortex. There are two constant connections. One is to the precuneus and one is to the superior frontal gyrus. Now coming back here, I will just show you because this is part of the limbic system. So this is the mammillary body. This is the mammillothalamic tract. So the fornix, which is coming down from here, from the hippocampus, will turn like this and come here to end in the mammillary body. So the fornix has two parts. Part of the fibers go directly to the septal region. So the septal nuclei are not harbored here in the septum. They are harbored here in the subcallosal region, and this is the septal region, which has septal nuclei. So some fibers of the fornix go directly into the septal region, and they are, as they are anterior to the anterior commissure, they are known as the precommissural fibers. And these are the majority of them form this. These are the postcommissural fibers, which end in the mammillary body here. And they go on, mammillary body goes on to give the mammillothalamic and the mammillotegmental tract. So here you see the close-up view of the same image. This is the anterior commissure. This is the mammillary body. Here again, you can see the parahippocampal gyrus as it is turning into the cingulum. Now let's go further. Now you see this, the gray matter of the parahippocampal gyrus I have removed, and you can see the radiation of the cingulum in this region. Now I'm depressing the radiation of the cingulum. And what do you see? You see this dentate gyrus. So the subiculum again turns medially and forms the dentate gyrus. And then again on that, the hippocampus will form. So the sulcus between the dentate gyrus and the subiculum is the hippocampal sulcus. And that is phylogenetically the first sulcus to appear in our human brain. The sulcus between this area, now you see this white band that is coming on the surface of the hippocampus, and that is the fimbria. The sulcus that separates the dentate gyrus from the fimbria is the fimbrio-dentate sulcus. Now, if you notice this, these denticulations, they continue above here. And as I told you, the callosal fibers invade this region. So the hippocampus, which is actually moving from this position coming down here, is invaded by the corpus callosum, but some of it remains. And this is the supracallosal part of the hippocampus or the subsplenial gyrus, which continues above as the inducium crisium, which you can see here. There's a thin layer of gray matter which goes all the way to the subcallosal region. And this region is this structure is the inducium crisium. Within it, there are two lateral striae, that is the lateral and medial longitudinal striae. So now you can see it very nicely, the hippocampus, the fimbria, the fornix, the mammillary body, the columns of fornix, and the anterior nucleus of thalamus. Going further, there is one more structure that comes here between the thalamus and the caudate head, and that is the stria terminalis. I don't see it in this image, but it runs here, that connects the amygdala to the septal region again, and it is also known as the dorsal amygdalofugal pathway. Once I remove this caudate head, I see the anterior thalamic radiations. This is just an overview before. So this is the anterior thalamic radiation, and this is the whole Pappes circuit. So you see the fimbria, the fornix, the columns of fornix, mammillary body, mammillothalamic tract, anterior nucleus of thalamus, anterior thalamic radiations going to the cingulum, and then the cingulum coming back down to end here in the entorhinal region. And this is how the whole system communicates with each other and gives the messages throughout the brain. Once you remove the whole fibers from the medial aspect, you see these structures, and that is the thalamic radiation. So this, the inferior most part of the thalamic radiations are the optic radiations. And this is how the thalamic radiations enter into the brainstem. This is the Pappes circuit dissected outside. Now this is how the hippocampus lies. As now we have to come to the surgical part of the anatomical presentation. So this is how the hippocampus lies and turns here. This region is the region of the hippocampal commissure or the saltarium. And here you see this thin layer here that is forming in front of on top of the hippocampus is the fimbria, which continues as the fornix. And this is how it lies on the floor of the temporal horn. Now coming to approaches to this region. So many approaches have been described. Professor Yasser Gill described this approach to the amygdala in the hippocampus, a trans-sylvian approach that directly led to this region. Then there is a middle temporal gyrus approach that has been described, an inferior temporal gyrus approach that has been described, and an infratentorial supracerebellar approach that has been described to this whole region, that is the mesial temporal region. This structure here running between the hippocampus and the thalamus is the choroidal fissure. Now let's see the anatomy of these approaches. So coming from laterally, so this is the lateral aspect, the lateral superior, middle, and inferior temporal gyri. I'm not going to go into details of that. Once you remove the fibers on the lateral aspect, this is the first structure that you, first fiber, long fiber that you will see, and that is the superior longitudinal fasciculus. Here you see the inferior longitudinal fasciculus, which comes when you're coming from below. When you come from the region of the collateral sulcus and the inferior temporal gyrus, the only tract that will come in your way is the inferior longitudinal fasciculus. Then this is the arcuate fasciculus as it is turning. So now you can see it very nicely here. This is the SLF. This is the arcuate fasciculus as it is turning down. More in the depth, you start seeing these two fiber bundles, the uncinate fasciculus and the IFOF. And here you see the region of the dorsal external capsule. So here you see the ILF, the uncinate fasciculus, the IFOF. Now, there are two structures that are important when you're performing surgery in this region. One is the sagittal stratum and one is the temporal stem. Now, what is the sagittal stratum? Stratum means a series of layers. So in this region, there is a series of fibers that come, almost 5 or 6 bundles of fibers that meet here on the lateral aspect of the horn, of the temporal horn. The lateral wall of the temporal horn runs the sagittal stratum. So the fiber bundles that are involved here is the IFOF. Then you have fibers of the anterior commissure. Beneath that, you will have fibers of the optic radiations. And beneath that, you will have fibers of the tapetum. Sometimes also the arcuate and the MLF also come in this region of the temporo-occipital parietal junction. So here you see, this is the IFOF, this is the uncinate fasciculus. Now I have removed the IFOF here and you see the optic radiations. So the optic radiations, we have already seen one Mayer's loop that comes, curves anteriorly and comes here. And then this is the posterior and the central bundles of the optic radiation. The last thing that will come here is the anterior commissure fibers. So once you dissect here and remove the globus pallidus, you will see the anterior commissure in the depth in this region. And you also start seeing the region of the internal capsule. So here you see the anterior commissure as it turns here and joins the bunch of fibers, that is the sagittal stratum. And lastly, the thing that you should never reach when you're performing surgery is the internal capsule, the anterior limb, the genu, the posterior limb, and the retro and the sublentiform part of the internal capsule. So that was the sagittal stratum. The next thing that is important is this, the temporal stem. Now, why is it called the temporal stem? So if you can imagine that this part of the temporal brain is connected to the mediobasal brain by these fibers in this region, and I will tell you these fibers, and it appears like an inverted tree, and that is why it is known as the temporal stem. So the first connection here is this transverse insular gyrus that connects the posterior medial orbital lobule all the way to the uncus. So the Lyman insulae or this transverse insular gyrus, that is the first connection of the temporal stem. Beneath that, you will have all these fibers. So the fibers are the uncinate fasciculus, the IFOF. Beneath that, you will have the connections of the amygdala to the posterior medial orbital lobule and the amygdalofugal pathways. So this region is the temporal stem. So when you're doing selective approaches to the amygdala through the trans-sylvian route, you generally go through this region. So the fibers that will be severed in this region are the uncinate fasciculus and some part of the IFOF. You will have to sever this connection because this severance disconnects the amygdala from the mediobasal frontal brain. So this is the selective approach. First, Professor Yasser Gill used to go through the Lyman insulae, and later on he modified the approach to go from the anterior part of the temporal pole. So these are the fibers in layers that you can see. So here you see some part of the IFOF. Here this is the dorsal external capsule. Here I've preserved the extreme capsule. This is the arcuate fasciculus. So these two structures are important. The last one that comes here is these horizontal fibers that you see here in the last part of the temporal horn, and these are the tapetal fibers of the callosal radiations. So we saw the selective approach causes problems by damaging the uncinate and the IFOF to sever its connection of the amygdala. Now we described an approach. We found an area in the region of the temporal horn, in the most anterior aspect of the temporal horn, which was devoid of any fiber bundles. Because you see this, the IFOF and the fibers of the optic radiation in the anterior part of the temporal horn are in the roof, and it's only in the posterior part that they go on to form the lateral aspect of the temporal horn. So if you make a corticectomy in the middle temporal gyrus and enter at this point, and then after disconnecting the amygdala, which will be in this region, so once you disconnect this portion and then remain beneath the roof of the temporal horn, you will avoid injury to this IFOF and to the Mayer's loop. So we described this approach, and we have been using all this. This approach was being done by Professor Goel long back, and we have then studied the fiber correlates of this. And this is the disconnection. So we enter through this area in the middle temporal gyrus, enter the temporal horn at that anterior portion, disconnect the amygdala, and then remain beneath the roof, and then make this whole resection, disconnect here at the tail of the hippocampus, and then carry out the disconnection all the way till you see the pia of the medial temporal region, and remove the whole portion en bloc. So you see here in this, I've put a pin here, and you can see in the anterior aspect of the temporal horn, these fibers are in the roof, and the posterior aspect, they are in the lateral aspect of the temporal horn. So here you can again see it very nicely. So if you come transsylvian, this is the fibers that you will disconnect. If you come from the middle temporal gyrus, you can avoid injury to these fibers. If you come from below, the fiber that I told you earlier will get disconnected is the inferior longitudinal fasciculus. Now, just to show you how the amygdala lies, why is it important to limit the superior extents of the amygdala? If you see in this image, you see there is no demarcation between the amygdala and the globus pallidus. It is in direct continuation. So you have to be very careful while you make this disconnection, that you do not go ahead and damage the globus pallidus or the central core of the brain in this region. So this is the area that you have to remove when you're performing mesial temporal lobe surgery. And again, this is an image showing both the sagittal stratum and the temporal stem. And I think that will conclude my lecture. Thank you very much.
It was an excellent talk, Abhida. Congratulations. Now over to Dr. Matthew.
Let me invite Suchinda to introduce our next speaker, that is Aribargan. Doctor.
It's my pleasure to invite our next speaker, who is Dr. Arivazagan from NIMHANS. He's the professor of neurosurgery there. And besides his epilepsy surgery interest, he also is a neuroendoscopic and neuro-oncology interest. He keeps interest in both of them. And he also has some exposure on epilepsy surgery abroad in Canada. And he has a huge experience on epilepsy surgery. So his topic is surgery for mesial temporal sclerosis techniques and complication avoidance. So over to you, Dr. Ari. Hello, Dr. Ari.
Yeah, is my screen visible?
Yes.
Yes, you're very much visible.
Yeah, just a minute, I'll minimize. Okay. Yeah, so good afternoon. I thank the NSI and the moderators for giving me this opportunity to present. So after listening to a very extensive lecture on neuroanatomy and microsurgical anatomy from Dr. Abhida, I think a lot of people should be getting concerned whether if you have to know all that before getting into this at all. Of course, that information is a treasure trove of knowledge, which is definitely will help us in not just in temporal lobe surgeries, but as well as in all brain surgery. So I'm trying to show the techniques and keep it as simple as possible. And let me see if I can do justice to that. So this is covered already. For any surgeon, neurosurgeon who wants to do epilepsy surgery or surgery for drug resistant epilepsy, surgery for mesial temporal sclerosis is a must. It is a simple surgery, but at the same time, it can become very complicated and it can result in devastating consequences. So it's important that it should be learned well and done well. And as is shown earlier, this is the most common indication for surgery in a case of drug-resistant epilepsy. So before one even considers surgery, as a neurosurgeon, it's important to understand there's a teamwork. The patient has to be selected very clearly by the neurologist, and the imaging has to be read by the neurosurgeon as well as the radiologist and the team. Unless you are convinced that this patient has hippocampal sclerosis, surgery should not be offered because it will result in failure. So the cardinal signs are the loss of volume of hippocampus, loss of internal architecture, and T2 hyperintense signal changes. And in addition, you can see, I think Dr. Ravi showed atrophy of ipsilateral fornix. There can be signal changes in amygdala. There can be dilatation of the ipsilateral temporal horn, and there can be atrophy of the temporal lobe of the same side. So I will go directly to case and show the surgical videos. So the first patient is a 17-year-old male who had seizure from since 8 years of age. Uh, MRI and clinical semiology and video AG all corresponded to a right temporal origin. And this was his MRI, and MRI showed, as you can see, there is atrophy of the right hippocampus, there is dilatation of the temporal horn on the right side compared to the left side. And you can see signal changes in the FLAIR images, uh, which indicates that's a hippocampal sclerosis. So, and this video AG showed spike waves in the right temporal origin. I think Dr. Abhita has covered all this, so I will skip all this. What is important to know is the surgical anatomy before we do surgery. And then I think Dr. Ravi Mohan will cover later about the selective apicapectomy. For ATL and EH, this is a diagram which you should remember. The surgical procedure involves removal of the anterior temporal lobe in right side about 4 centimeters from the pole, and in left side about 3.5 centimeters, and the mesial temporal structures which involves the amygdala and the hippocampus involving body and head of the body and the head and the body at the, and it is disconnected at the body tail junction. So just a diagrammatic representation of the structures and the surgical technique. So there are a lot of surgical techniques which Dr. Abhida mentioned. At the same time, here also what I have seen, there are many ways of doing this, both us and the colleagues. The surgical technique which I will show is what I learned from my mentor and teacher, Dr. Chandramouli, I think is there in the audience. So the first step is to enter the temporal horn. So the first incision will be on the lateral surface of the temporal lobe, 4 centimeters from the pole in right side and 3.5 on left side. It's a vertical incision through the middle temporal gyrus and straddling the superior temporal and infratemporal sulcus, and then dissected deep to enter the ventricle. Once the ventricle is entered, then the temporal horn is opened from posterior anteriorly to expose the whole structure. So, and this is a same structure and same procedure in coronal. So the first entry is from the middle temporal gyrus deep down to the goal is to enter the temporal horn, and then the last cut will be to make a cut down through the parahippocampal gyrus through a groove. You will see a groove nicely in during surgery, and this groove cut will take all the way down to the floor. And then to disconnect the temporal lobe, we will do a subpile dissection along the superior temporal gyrus. This is a pile incision which will be made on the superior temporal gyrus, and then the whole temporal lobe is dissected out. So let me show you in the video, then you can understand. There are many ways of removing temporal lobe. What I do, this about 4 centimeters measured from the pole. This is a right temporal, the same patient's right temporal surgery. This is for orientation. This is frontal, this is William Fisher, this is middle temporal gyrus entry, and this is a floor. And we made a vertical incision along the middle temporal gyrus, and then in dissection is done to deepen to identify the temporal horn. Temporal horn, you can see when as you reach, you will see a thin structure and thin vessels running as a part of the ependyma. You enter the temporal horn. Once the temporal horn is entered, the temporal horn is opened from posterior anteriorly to expose all the structures. The bulge that you see on the roof is the amygdala, and then you see the whole ventricle, and you can see a groove here. This groove is what I showed. If you go along the groove down towards the base, you will reach the pia of the uh, parahippocampus, reaching the MCF base, and then the uh, parenchyma is removed and the part of the parahippocampal gyrus to expose the pial surface. And once that is done, the posterior incision is made from the middle temporal gyrus incision all the way down to the temporal base. And again, it is disconnected. This is a posterior disconnection of the temporal lobe, and keeping the pia preserved below. The temporal lobe is disconnected. Then the only thing that's left is the superior surface. Here we make a pile incision all along the superior temporal gyrus, just close to the sylvian fissure, along the uh, sylvian vein. And once you make a pile incision, then a sub-pile dissection of the superior temporal gyrus is done. You can see the pia can be held with the microbayonet and then dissected sub-pile. You can see there are the branches of the MCA that is coming into the view, and then the whole MCA can be seen. When you do sub-pile dissection anywhere, you should see the surface of the brain should be totally white. The vessels are all in the pile plane, and when you do sub-pile, it's totally white. This is a temporal stem which Dr. Abhida showed in anatomy. That is your posterior limit. Once that is done, the superior temporal gyrus is disconnected. The vessels that run in superior temporal sulcus is cut, and then the whole lateral temporal cortex is again disconnected from ventricle. You have to understand this whole surgery is through the ventricle. So the key is to enter the temporal horn. If you do not enter the temporal horn, further surgery is going to be difficult. So this cut, the superior temporal sulcus is cut perpendicular to the temporal horn, or from the temporal stem all the way to the pole, and then the pia that is holding the temporal lobe is coagulated and cut. You can see the basal incision and the superior incision is joined at the temporal pole, and then keeping the pia intact medially, the temporal lobe is removed in toto. There are many ways of doing it. This is how I do it, what was taught to me by Dr. Chandramouli. But there are many ways of doing. The easier way of doing this would be to just take out doing a standard temporal lobectomy of middle temporal gyrus and inferior temporal gyrus, and then sucking out the white matter to enter the temporal horn and doing the surgery. And the superior temporal gyrus can be, I have seen people removing separately or can be removed using suction. But what is important is all the three gyres we removed. We remove this like this so that we have a specimen for an understanding. The second part of the surgery is removal of the amygdalo-hippocampectomy. Here the surgical technique, we have already made this cut. This is a groove. I told that you will have a groove on the floor which can be cut to join. And this cut is already made when you do the lateral temporal lobectomy. And now we make a cut here. And then we make another cut here, and the whole amygdala is removed separately, and the whole hippocampus head and the body can be removed. That is a second stage of surgery, and last uncus will be removed. Sorry. So after lateral temporal lobectomy, this is the structures you will see. This roof, what you see in the roof is amygdala, and what you see in the floor is hippocampus. You'll see the head of hippocampus here and the body. And this is what is important. There is no anatomical division here. This is very important here. I'll go again. When you remove the amygdala, what is removed is only the lateral two-third of amygdala. I use a number 2 dissector. Just remove the amygdala which is projecting into the temporal horn. If we enter here and go more medially beyond, you will end up injuring globus pallidum, as well as if you go deeper, you will go to the internal capsule. This is where the internal capsule is very close medially. You should be careful while dissecting here. So this amygdala is removed separately, and then I dissect the hippocampus. Some people remove amygdala and hippocampus together, can be done, but this is how I do. So once the amygdala is removed, you can see this is a head of the hippocampus, this is a body of the hippocampus, this is a choroid plexus, and this is a choroid fissure. And this is the junction between the body and tail. There are different ways of measuring. What I do is I measure 3 centimeters from the pole, and then I mark it. That is the same point which the body and tail corresponds to, tail junction corresponds. The other way of looking at it is where the wider body becomes a narrower tail. That is where I make the posterior limit incision marking. And then again, the hippocampus is dissected subpili, keeping the pia intact. And this is a cut, we make anterior cut where the head of hippocampus is released from a part of the uncus. This part of the brain also comes out, but I usually remove it at the end, because this is behind, deeper to that is where the ICA, anterior choroidal and other structures. So I keep it till the end. So make a cut here till you identify the hippocampal sulcus. Between these two structures is a single pial sulcus, which is the hippocampal sulcus. That is what is holding this. So after we make this cut here, we open the choroidal fissure. Choroidal fissure again has to be opened subpially using a micro dissector. Slowly just peel off the fimbria, keep the pia intact medially so that the veins and the structures are there. You will have to again see a whitish surface. And once you dissect, the subpili, the subpili, once you dissect the choroidal fissure, then this cut is completed so that the whole head of hippocampus is released. You can see that. And the pial surface, the sulcus here that you see here is a hippocampal sulcus. So once anteriorly it is cut, I also cut the fimbria posteriorly. So that is a hippocampal sulcus that is coming into picture. Then I dissect the fimbria and cut the fimbria posteriorly to expose again the hippocampal sulcus posteriorly. Once that is done using a number 2 dissector, this whole hippocampus can be flipped, can be rotated on itself. It had already rotated. We are just reverse rotating over the itself and exposing the whole of hippocampal sulcus. This hippocampal sulcus contains branches that come directly from the PCA. So when some people coagulate and cut, I do not coagulate. You have to reach to the apex of the hippocampal sulcus. Once you reach using microbayonet, you can just gently peel off the whole pia downwards and then dissecting the whole hippocampus subpile. You can take it as posterior as you want. So you see, you can just, the hippocampus is just getting delivered easily. The whole pia gets stretched off. And where we had marked the posterior limit of the hippocampectomy, that is about 3 centimeters behind, the cut is deepened down all the way down to the parahippocampal gyrus and then dissected off. So this is a hippocampus specimen. You can remove more posteriorly if you want. Some more hippocampus can be dissected off, and either you can use CUSA or can cut and take. I usually do not use CUSA for this surgery. And the last part of it is to remove the uncus that we had kept. That is removed, I think, and in this case, and then it's closed. So this is a specimen, 3 centimeter long hippocampus, and this is a dentate gyrus region, subiculum and dentate gyrus region, and it's all subpili dissected. Another case, 27-year-old man who had multiple seizures in 3 years of age. This is a left hippocampal sclerosis. You can see MRI shows dilatation of left temporal horn and signal changes in the left hippocampus. PET shows hypermetabolism of the left medial temporal as well as the pole. And I'll just show, because the previous one was on two times speed mode. This is after removal of the lateral temporal lobe. Here we are, this as the speed as during surgery edited. So after removal of the lateral temporal cortex, you can see that this is a amygdala which is bulging into the temporal horn, and this is the head of the hippocampus. And amygdala, you can see this is a pia of the Cillian fissure. Lateral 2/3 of amygdala is dissected. Usually, since amygdala is a gray matter, you can see difference in color in the amygdala. So the amygdala is removed separately up to the head of hippocampus. You can keep it together and remove it also, but I usually remove amygdala separately and send it as a separate specimen. And then the hippocampus head is disconnected at the anteriormost part by making a incision on the ependymal surface. And then using suction, it is taken down all the way to the pia. And this here, the hippocampal sulcus is very thin, and see, as I dissect, I've already opened, and so CSF is coming out. Once I made a deep cut here, I opened the anteriormost point of the choroidal fissure. That's where the you can see the anteriormost part of choroid plexus. The choroidal fissure is open, dissected subpili. You can see I'm just lifting it gently and then cutting this and completing the disconnection of the head of hippocampus. And then once it is disconnected, you can roll it off from the pia. You can see this is a hippocampal sulcus pia. So there will be two parts of it. This is a parahippocampal gyrus. This is a part of hippocampus. You can roll it slowly so that the hippocampus lifts off. And once it is adequately lifted, I have also cut the posterior side, and you can see as I slowly and carefully roll it. You should be very careful here because excessive traction can cause injury to the vessels which come here. These are the PCA perforators. If you cause excessive traction, vessels it can snap off from the PCA, and this is where the anterior caudal also goes. So this has to be done very carefully. You have to reach up to the apex of the hippocampal sulcal pia, and once you reach, just with the microbayonet, you can hold it and peel it off. You can see how easily it peels off. Sometimes it peels well, sometimes it does not. If it is a tumor, then it is more difficult to get this because the tumor may infiltrate the payas, in which case you can use QSAR to thin it down. And usually there is no need to coagulate any of the vessels. You can just hold them. You have to hold them at the apex and pull, then one will comes. Once it is done, you can roll the whole hippocampus over the paya posteriorly and make a posterior cut here. This is again 3 centimeters from the pole, or where the body turns into tail, narrow tail, or where you can see the curving, medial curving of the body of the hippocampus. What is described as reaching to the colliculus, all that, we will not be able to see the colliculus in this surgical field. So you have to keep this surrogate markers. So once that is done, the hippocampus is dissected subpili and the specimen is taken out. So then final thing is to dissect the uncus is what I do. You roll the uncus. Why? Because below the uncus is where all the important structures are there. You can see the ICA coming into view here. And you can see the third nerve. Everything is behind a paya. So they are all preserved. There's a third nerve here. There's ICA. There's a PCOM and there's a anterior choroidal. So some people remove this in the beginning. I usually keep the uncus till the end so that these critical structures are preserved, are kept safe, and then remove the uncus. And you can see now the ICA, choroidal, PCOM, and the third nerve. And then remove the redundant excessive uncus, and that completes the surgery. So this is how the specimen looks. This is how normal hippocampus looks in the section, whereas this is how sclerosed hippocampus looks. You can see all the changes. I will not go into detail. Dr. Ravish has covered. So coming to complications, as we all know that complications can happen in any surgery. The most important things about epilepsy surgery is that people do not, the patients as well as the neurologists do not expect or accept complications that easily. That said, there is a risk of complications, various types, up to 3%. So one needs to be very careful. How we can avoid? Diligent techniques and meticulous procedures. So it can result in hemorrhage, it can result in infarction, because we are working around all the critical vessels. We're working around MCA, we're working around PCA and choroidal and ICA. And of course, there can be infection following surgery. There can be, like Dr. Abhida showed, injury to Meyer's loop can result in contralateral homonymous superior quadrant defects. And some patients we have had who have developed psychosis, mania following surgery. So I will not go much in detail, but this is a paper that we wrote, which is published in Acta Neurosurgica supplements, where we have described all the complications that we have encountered as well as what is known. So sometimes you can have this large. So I will suggest the audience to go through this chapter, which is very elaborate and very extensive. So sometimes you can have these kind of large veins running in the middle of your operative field, preventing you to actually resect 3 or 4 centimeters. In which case we'll have to be happy with the small temporal poles exposure and then do the hippocampectomy. Sometimes the vein of Labe can have multiple branches, again affecting the surgical technique, in which case we need to modify our lateral temporal lobe resection accordingly so that these veins have to be preserved. This patient had a left temporal surgery that for left hippocampal sclerosis, and post-operatively developed edema, and also showed we had to do angio because of there was vasospasm and small infarcts. He developed hemiparesis post-operatively, right side hemiparesis, as well as altered sensorium, which improved over a period of time. The DSA showed areas of spasm, which improved over a period of time. This is another patient. This is something which we should not have during surgery. This happened in this patient where he underwent right-sided temporal lobe surgery, and probably due to retraction or dissection at the region just above the globus, above the amygdala region, most probably due to retraction, he developed an hematoma close to the, you can see as how close it is to the hippocampus, close to the internal capsule and globus pallidum. And he developed hemiplegia, left-sided hemiplegia, which took most 2 to 3 months for improvement. How to avoid complications? To conclude, stick to the anatomical landmarks, be very clear as to what we need to remove and what are the critical structures around it, and realize the variations in anatomy and subpile dissection in the region of the Sylvian fissure and the medial temporal structures. I do not use coagulation once I've removed the lateral temporal lobe. I do not use coagulation anywhere in the region of the medial temporal structures. It can be done without any coagulation. All small bleedings will stop by itself, and preserve all vessels medially and achieve complete hemostasis. In anterior temporal lobe stage, how to avoid complication? Enter the temporal horn. If you are not getting temporal horn, if you're not sure where it is, if you're searching, then err inferiorly, because even if you go by you, even if you miss the temporal horn, you will go and reach only the MCF base. Whereas if you start searching superiorly, if you go above the temporal horn, because this is a very narrow temporal horn, if you go above the temporal horn, then you would have gone over the roof of the temporal horn and you will directly land in globus pallidus and the internal capsule, which is very, very devastating. So, but without entering temporal horn, this surgery cannot be completed. Then preserve the pia inferiorly along the Sylvian fissure, as well as preserve all the Sylvian veins. In the hippocampal resection stage, anteriorly remove only the lateral portion of the amygdala. Do not dissect above the choroid plexus. The whole surgery is below the choroid plexus. There is no need to go above the choroid plexus. And preserve the medial pia to choroidal fissure and uncus, so that all this may not be possible always, because sometimes the pia is very thin, it may open up, no problem, but preserve as much as possible and try every time. And if there's a small pile breach, put a cotton, and do not enter or dissect the structures which are the PCA and PCA perforators, which are medial to this pia. And gentle dissection of the pia of the hippocampal sulcus will prevent any injury to the perforators from the PCA. Avoid traction. So what is important is to have a multidisciplinary workup, which will give good outcome. This paper is known to all of us from Sam Weeb, which has proved that this is a surgical technique far outweighs medical management. This was our results published about a decade ago, of where we had shown we had about 78% Engels class 1 outcome for mesial temporal sclerosis. So to conclude, ATL in H is a very simple and meticulous technique, but what is important is to have attention to detail in every step to avoid morbidity. And this procedure has to be learned by any neurosurgeon who wants to do surgery for drug-resistant epilepsy. Thank you. And this is our team. This is never a single person work. It's a big team that we work together to achieve what we can for the patients. Thank you.
Thank you, Dr. Eddy. It was excellent as usual. And now I hand over to Dr. Matthews for the rest of.
Let me request Dr. Kodiswaran to introduce Dr. George.
Dr. George Villanellam is a professor of neurosurgery, Sri Chitra Trinal Institute of Neurosciences, Trivandrum. His special interest in epilepsy surgery, and he has trained a lot of neurosurgeons from various countries, and he's a mentor faculty for epilepsy surgery program in SGPG Lucknow, AIIMS Jodhpur, and National Hospital of Colombo. It's over to Dr. George Villanellam.
Thank you very much, sir. It's an honor to be here, especially before my teachers, Professor Chandramouli and Dr. Matthew, who taught me the earliest steps in epilepsy surgery. I must profusely thank the NSI Webinar Committee for their painstaking efforts, Dr. Kodiswaran and Professor Matthew. Thank you so much. And it is very exciting to see more than 70 to 80 neurosurgeons for a functional neurosurgery webinar. I like this term functional neurosurgery because it makes us functional neurosurgeons feel more functional than the less functioning other neurosurgeons. So temporal neocortical epilepsy is a fascinating field. And why it is fascinating, maybe, if you look into these questions, you can understand it better. Sometimes you have, very perfectly done amygdalohippocampectomies. The stage was so nicely set by my earlier speakers, Professor Arivaragan, Dr. Abida, and Dr. Ravish, who, showed us how to do it so perfectly well that you can probably get the feeling that you can never fail. So in such situations, can it really fail? And you also feel that you're removing so much of extended lateral temporal resections. Can that, it's like burning a haystack to kill a small mouse. So probably the mouse can never escape, but that's not always so. And the next question is that how much of lateral temporal lobe resections are actually just enough. Doing too much is also difficult, can have its problems. Too little also its problems. What are the adverse events and what are the outcomes? So with this background, let me introduce this topic with the concept of the neocortex. The neocortex actually means that over a period of phylogenesis, over evolution, we can see that we are the most evolved species and we continue to evolve. So our temporal lobe is the largest, perhaps in the living race, and its functions even are continuing to evolve. So I have structured my talk first by introducing some basic concepts like the concept of neocortical epilepsy compared with mesial temporal epilepsy. And the next I would introduce the concept of secondary MTS, and then finally come to the evaluation of outcomes and adverse event prevention, especially showing some illustrative cases, and then to end with the concept of the learning curve in epilepsy surgery and future perspectives. So the temporal lobe, is a very, very complex lobe and very exciting because it has got all the three phylogenetic areas of the brain. That is the allocortex, the mesocortex, and the neocortex. And our area of interest today is the neocortex. And as Gloor has very rightly said, it's perhaps the temporal lobe which is giving us this sense of being, the sense of the human experience. So the temporal lobe, as you can see, has it all, and almost 90% is the neocortex. The mesocortex is a little less than that, and the allocortex, which is the most primitive form, the hippocampal formation and the primary olfactory area, is the smallest perhaps in volume. But it is interesting to see that the smallest in volume is perhaps the most seizurogenic, is something that we have to think about. So this is the same thing in a little more diagrammatic and a colorful fashion. And if you look at the brain in terms of volume, each hemisphere in an adult is about 1100 cc, and the temporal lobe is maybe about 17% of the brain volume. Yet the very, very interesting and exciting question is that 60 to 70% of seizures are from this part of the brain. And you can see that the middle fossa in the humans is very, very voluminous, showing that our temporal lobe is much more voluminous than all other species. And the term tempus, if you want to schematically represent your temporal lobe, just put a closed fist in front of you. The thumb represents the temporal lobe. If it's your right hand, this is the right temporal lobe. Left hand, it is your left temporal lobe. So why the term temporal? Again, because the graying of hair, I've got some graying already beginning here in the temporal region, and over a period of time, temporal actually means over a period of time. So what lies below the temporal bone is the temporal lobe. So why the temporal lobe is the center of epileptogenicity? Because it's vulnerable to excitotoxicity, autoimmune insults, and neuroinflammation. So even in a resting state fMRI, perhaps it's the temporal lobe that is the most active. And we have learned that there are so many structural and functional connections in the temporal lobe. And the temporal lobe epilepsy can be described as something which is originating in the temporal lobe. That is, the temporal lobe is a pacemaker or which is relayed to the temporal lobe. So we have mesial temporal epilepsy, which is the commonest, about 90%, and then we have neocortical temporal lobe epilepsy, which comes from all these yellow shaded areas, which is just about 10% of temporal lobe epilepsy. So the big question is that you can be easily fooled, even if you're the best epileptologist or best epilepsy surgeon, as to where the seizure is actually coming from. So that's because of a schematic like this, wherein you have a pacemaker where the seizure can begin from the temporal lobe and it can propagate to another area. So you don't know whether you're dealing with the pacemaker or the early propagation. And then there are some other non-involved areas which are also probably potentially seizurogenic, and they're just waiting for that opportunity to join the circuit. So if you have neglected epilepsy, surgical referrals for long, you could have surgically refractory epilepsy also coming up because of a lot of other nodes which might become epileptogenic. So in TLE, the big question is that is the seizure coming from the hippocampus, which is the commonest, or the amygdala 10%, or the lateral neocortex, or a small percentage which is known as temporal plus, which is beyond in the peritemporal lobe structures like the insula, the parieto-temporo-occipital junction, the orbitofrontal cortex. So this is, it's very easy to put up a classification or a differentiation slide like this, but in reality, sometimes you can have mixed epilepsy, which is partially mesial, partially neocortical. So not very easy always, though we have some clear differentiating points, which Ravish very nicely put up. So temporal lobe epilepsy, based on the site of origin, also you have a classification. Those who are fascinated as surgeons, we really don't care too much about the seizure semiology. We are interested in structural abnormalities and setting the structure correct. But often we need to really understand and in depth the semiology as well, so that we can do full justice in understanding the network. So you can see that there is a hippocampal amygdala type of seizure semiology. There's a tempopolar, which is more of autonomic changes. There is a lateral neocortical type of semiology. There is an operculoinsular, which has more of auditory and visceral aura, mainly because it involves the Heschel's gyrus, the primary auditory area. And you also have an extratemporal type of semiology, which can sometimes manifest as a pseudotemporal epilepsy. So when you're faced with a difficult network, the question which comes before you is that you want to resect, disconnect, ablate, or stimulate. And resect, it has the problem of loss of function. Disconnect, because you might not, however good you are, you might have something undisconnected. Our epileptogenic zones, sometimes the temporal lobe are just too big for ablation. So, laser, RF, SRS have their own failure rates. And stimulation, again, benefits are transient and the targets are really very huge for them. So we know the basics of epilepsy surgery. The difference with conventional neurosurgery is that the abnormality is not equal to the MRI structural abnormality. So we are looking for the epileptogenic zone, which is not really equal to this abnormality. Here there is a left temporal ganglioglioma, but the epileptogenic zone, what it is, we will know only when we succeed after surgery. So it's something beyond the structural abnormality. So you have irritative zone, which is the EEG abnormality. You have got the symptomatogenic zone, which is in this case is the speech arrest produced by the vernix area, which is a part of the early network. And the acute electrocardiography has its own role, and intraoperative, which is done intraoperatively, and chronic invasive EEG also has its own role in temporal neocortical epilepsy. This we are all aware of, the basic workup. Going up further, almost 80 to 85% of patients can be recruited for temporal lobe epilepsy surgery with just the basic two investigations of MRI and a video EEG, and we're looking for good concordance. These are the new kids on the block: MEG, the ictal SPECT, the arterial spin labeling, which is known as the poor man's PET scan. They also have their evolving role. And, we are looking for hypoperfusion. We are looking for a new entity, which sometimes is known as MR negative, but PET positive TLE, where you can actually operate without an invasive EEG and get good outcomes. So there are some patients with the ideal surgical resections also may have surgical failures. This is because of the concept of secondary epileptogenesis, or the network, other areas which are secondarily epileptogenic due to late referrals, where the network becomes very strong and profound. And these are the spectrums of epilepsy resections. And in adult epilepsy surgery, still 2/3 is temporal lobe epilepsy surgery. And this is the spectrum of epilepsy resections. The commonest is the cortico-amygdalohypocampectomy, also known as the ATLH. The selective amygdalohypocampectomy, we have electrocorticography tailored resections, we have multilobar resections, and the temporal lobe sometimes can also be resected as a gateway for other skull-based exposures. So temporal resections, 65% of adult epilepsy surgery, they were introduced in the 1950s. Earlier resections were more neocortical, less mesial. Then the shift of focus occurred and more mesial and less neocortical. The present day technique, as Dr. Ariwalagan very brilliantly demonstrated, is a lateral neocortical resection followed by the mesial temporal resection, slightly different in the dominant and non-dominant. And this is the current standard of care: 4 centimeter dominant, and non-dominant can go up to 5.5 or 6. So sometimes, you find elegant ways to do a selective amygdalohypocampectomy, but how selective you have to get, is tailored based on the pathology which you're treating. So this is the spectrum of the temporal pathologies. The commonest, again, mesial temporal sclerosis. And this is the whole subset of which usually could contribute to neocortical or lateral temporal lobe epilepsy. So this is a snapshot of many of the neocortical temporal lobe epilepsy, ganglioglioma, the cavernomas here, large D-nets. You could have sometimes a dual pathology, an orbital FCD with secondary hippocampal sclerosis. You could have a cortical venous malformation, a AVM with drug-resistant epilepsy, and sometimes extended lesionectomies which don't conform to standard guidelines or lobar resections may be needed, especially in cortical dysplasia, long-term epilepsy-associated tumors. They may be tailored according to electrocorticography. And I'll quickly show you a video. This is just to illustrate that intraoperative electrocorticography sometimes can be useful, especially in focal cortical dysplasia. So we do that before our standard resection. This is the standard right temporal neocortical resection, almost similar to the one that Dr. Alivargan showed very brilliantly. So you coagulate the surface pia, arachnoid, and then you resect the lobe en masse. So en masse resections are characteristic of epilepsy because it helps you to quantify the extent of disease and prognosticate better. So unlike a glioma where you resect piecemeal, here the resections, I'll just fast forward this in the interest of time. So this is an en masse large temporal lobe dissection. And after that, the temporal lobe dissection, we dissect open the temporal horn. And then we go into the mesial temporal resection. So that has been already covered. So I go to the next slide. And en masse resections almost look like this. And this is the bed of the resection, which actually shows you the basilar artery, the oculomotor nerve, sometimes even the fourth nerve. And one look at this tells you whether you're anatomically perfect in your resection. And hippocampal sclerosis histologically looks like this. But whenever you see this, you probably can't answer the question on whether it is a primary hippocampal sclerosis or secondary. In other words, is it the cause that is due to a long-standing, a childhood febrile illness causing hippocampal sclerosis that caused the epilepsy, or is it due to recurrent seizures? Because the temporal lobe or the hippocampus is like a sink which absorbs all the seizures which happen all over the brain, and it could be sclerosed over a period of time. And this is the histological classification, which Dr. Arivalgan had already covered. So we have the commonest, which is usually the CA1 type of predominant ILA type 1 secondary hippocampal sclerosis. And this is the typical situation where you have an insular FCD and a secondary hippocampal sclerosis. Many other lesions could cause secondary hippocampal sclerosis. So, all hippocampal sclerosis are not alike because we have got sub-networks within the hippocampus itself. So many of these sub-networks may be more active in some patients, less active in the others. The extent of hippocampal sclerosis has nothing to do with the prognostic outcomes, though that is why this sub-classification was very essential. We have T2 relaxometry, hippocampal volumetry. All these are evolving fields for evaluating the prognostic outcomes of hippocampal sclerosis. So this is how usually the extent of resection looks like. Extended resections, which may involve the parieto-occipital lobe, known as posterior quadrant resections, may be part of the hippocampal perspective of multi-lobar resections. So we usually use the term ATLAH or cortico-amygdalo-hippocampectomy, but actually it's a myth because what we're doing is a total anchectomy, subtotal amygdalo-hippocampectomy, partial hippocampectomy, and partial parahippocampectomy, and transection of the temporal stem. So we also think that one size type of standard resection fits all. No, that's again a myth, because tumors which are lateral to collateral sulcus, you just need to do an extended lesionectomy. You do not resect the medial temporal structures. While those which are medial to the collateral sulcus, you resect the medial temporal structures. And in children, there's a less role for selective resections. So, though these are a spectrum of medial temporal tumors, the extent of resection will be slightly varied in each of these patients. So adverse events, they are tolerable, and the more you get, you become better at it, you reduce your complication rates. And Dr. Harvalgan has very nicely covered. This is an anterior choroidal artery territory infarct, and we will look into how we can avoid it. This could even happen in neocortical without medial temporal resections. You might actually transgress through the ventricle, as Dr. Ari said, and go across the ventricle without realizing it. So you could have this even if you're not resecting a medial temporal lobe. And manipulation hemiplegia is what Penfield called it. Sometimes you have a lot of venous anomalies. So what you can do is to resect in between these venous anomalies, because the cortex is responsible for the seizures, and you really don't need, you need to make an effort to preserve these veins. Visual outcomes, we used DTI for evaluating the Mayer's loop, and we found that, there is a lot of variation in the lie of the Mayer's loop. So the broad understanding is that, as Dr. Abida also very rightly said, is that limit the neocortical resection as much as possible for typical mesial temporal sclerosis. Try to remain lateral to the roof of the, when you're opening the temporal horn. Because though it is just a quadrant anopia, it can be sometimes a very debilitating deficit for some people. And we published these landmarks of temporal lobectomy in a neurosurgical focus video, and we divided them into cisternal, parenchymal, and vascular landmarks. Having this sort of division helps you, because the temporal lobe is a sea of brain parenchyma, and especially in very large diffuse infiltrating lesions, sometimes you can get lost. So you need these landmarks to let you know where you are and to ensure safety of the procedure. These are the difficult cases: red flags, bilateral MTS, wasted hippocampal syndrome, temporal plus, and MRI negative cryptogenic epilepsy. So some of these patients require invasive EEG, and the typical indications in temporal lobe epilepsy are imaging negative focal epilepsy, eloquent cortex, you're close to the Broca's or the Wernicke's area, failed resective surgery, ambiguous electroclinical data, multiple lesions, and sometimes it also helps you to do adjunctive procedures like thermocoagulation. So this is how it is done. You have subdural strip and grid electrodes, and you have got SEEG electrodes. And this is the new kid on the block, is the SEEG electrodes. And you have situations wherein you could use a subdural, or you could use you could use SEEG electrodes. So these are the scenarios how you can select between the two. And I'll quickly show you an illustrative case. This is a T2 hyperintense lesion in the amygdala with secondary hippocampal sclerosis. The histology came as a surprise: hypercellularity and CD4 positivity. It was a tumor, and this is a newly evolving histological diagnosis. There is also hippocampal sclerosis with Ammon cell sclerosis, and this is astrogliosis, and this is the diagnosis: a polymorphous low-grade neuroepithelial tumor of the young, plenty. So there is a lot of plenty these days. This is a temporal lobectomy which had failed almost, which looked like an ideal ATLAH to us. And then we went in again, placed invasive EEG electrodes covering the peri-insular cortex and the parieto-temporo-occipital region. We found very focal onset from the PTO junction and resected that, and found very good outcome. This patient had got right-sided hippocampal sclerosis, but EEG showing seizures from the left side. Again, depth electrode placement placed in the hippocampus showed seizures to be coming from the abnormal side, which actually proved the concept of a burnt-out hippocampus syndrome with good resections of the right side, giving good outcome. This is another patient who had two different semiologies and two dual pathology: a left temporal FCD and right operculoinsular dysplasia. We did a stereo EEG placement bilaterally and proved that the left side FCD on the temporal lobe was actually innocuous, and just did a unilateral resection with good outcomes. So at 1 year follow-up, the patient had a Engel's class of the unilateral lesion. Electrocardiography done during surgery. This is a DNET ganglioma. We used electrocardiography. This is the pre-op recording showing diffuse ictal spikes and post-op showing reduction in the spikes. And we did a large randomized trial using this data, and we found that electrocardiography actually did not help much in improving outcomes. These are the outcomes of extended resections beyond temporal lobe, not as good as the pure temporal resections, but still very encouraging. And to prevent adverse events, we sometimes need to resect in between veins, and we use this term called endopile in intervascular resection. And this is how the learning curve of epilepsy surgery goes. Starting off with the smallest lesionectomies, and temporal lobe epilepsy is usually the starting point where we usually begin as learning or evolving epilepsy surgeons. But it is during this stage that we can sometimes go wrong. Comparison of outcomes between medial and lateral temporal lobe, little less optimum outcomes, but more or less almost comparable. And this is the new kid on the block doing endoscopic amygdalohippocampectomy. Let me just quickly run through this video. This is left ATL, right ATLAH, which we did endoscopically. And in the interest of time, this is a very small incision and a 2 centimeter craniotomy. And this is how the procedure we were able to resect both the lateral neocortex and the medial temporal lobe. And perhaps this is what our patients would probably demand from us in future, because everybody keeps asking about keyhole surgery, keyhole. So this is how the incision goes. This is how the endoscope gives you a very nice three-dimensional view. And this is the neocortical resection. And we were further able to even do the medial temporal resection through the endoscope. Arm mass resection was not compromised just because the endoscope was used. This is the temporal horn, the collateral eminence, and the collateral sulcus coming into view. The temporal horn was dissected open, and I'll just fast forward this video in the interest of time. And this is the neocortex being resected. And after the neocortex, this is the end mass resection, arm mass resection of the neocortex. After that, we open the temporal horn further, and the rest of the steps are the same. Once you're thorough with the anatomy and the other landmarks are favorable, you can easily do it endoscopically as well. And this is the choroidal fissure being dissected open, the amygdala being dissected open. And we were able to get almost the same resection outcomes as this is the hippocampal sulcus being dissected open, and the pia of the hippocampal sulcus vessels being coagulated. And yeah, I think I'll just skip the next. This is the PCA PCOM, the basal vein of Rosenthal, third nerve, the resection bed after the endoscopic approach. So the evolving biomarkers are high frequency oscillations, which are above 80 or 250 hertz, and they have very good biomarkers. And let me end with this very, very important message. Neocortical temporal lobe epilepsy is 10% of surgically remediable epilepsy, but we have to be wary of it. We have to suspect it and be very careful while diagnosing it. Secondary MTS, again, is 15 to 20% of MTS, usually associated with dual pathology. So if you find an MTS, don't think you have hit jackpot. Look beyond that. Look for abnormalities in the semiology. Look for other lesions. Robust workup and high index of suspicion is very essential. Failed temporal lobe epilepsy surgery, do not get disappointed. Reinitiate a pre-surgical workup. There might be a chance for a cure again, because there could be a residual neocortex or mesial, which is a contiguous, or it could be a missed dual pathology, missed extratemporal. Change of perspective, not just a lesion, but an epileptic network is very, very essential when we look at this. This is our neurosurgical team to whom I'm very, very grateful. And here you can see our team at the Madhavan Nair Epilepsy Surgery Center, whose robust workup has made all these good results very, very much possible. You can see Dr. Matthew here at the right here. And let me end with these very important words. Sometimes we make things very much simple, but sometimes we may not be able to simplify them very much. Thank you very much.
It was a wonderful talk, Dr. George.
Thank you, sir.
So we are running short of time. We'll move to the next speaker. Over to Dr. Matthew.
Yeah, let me call Dr. Suchanda to introduce Dr. Ravi Mohan Rao.
Yeah, so we have almost come to the last topic now, and that is again a very important one, though not as widely as practiced like the classical ATL and AH, but none other than the speaking will be by none other than Dr. Ravi Mohan Rao, sir, and he is practicing in Bangalore, and we are very fortunate to him. He has a huge experience on epilepsy surgery right from his Srijitra days, and now in Bangalore also he's practicing, and he's a regular speaker in all epilepsy surgery forum. Over to you, sir, for your talk on this one.
Thank you so much, Dr. Suchinda. Can you see the screen of my computer?
Yes, sir.
Thank you.
Just enlarge it, yeah.
So we had a wonderful session so far, starting with Dr. Ravish talking on clinical aspects, then Abhida showing wonderful orientation of the anatomy of the temporal lobe and related structures, and then Dr. Arivalagan and Dr. George showing wonderful surgical videos. They've all made my job very easy, so that now I have to only put forth arguments of why selective amygdalohippocampectomy and why not anterior temporal lobectomy, vice versa. So this is my team. Dr. Sujit and Dr. Dinesh Naik are my neurologists who work up my cases. So a standard temporal lobectomy can vary from conventional en-bloc antetemporal lobectomy to anteromesial temporal lobe resection with limited lateral temporal neocortical resection, which George alluded to. You can use it in the form of temporopolar approach, for example, if you want to limit the lateral neocortical resection, or go through one of the approaches used for doing a selective amygdalohypocampectomy. Randomized control trials using the standard approach, that is the conventional en-bloc ATL, have demonstrated significantly greater chances of seizure freedom and improved quality of life at 1 year and 2 years after surgery compared with medical management alone. Selective amygdalohypocampectomy is designed to preserve the temporal lobe neocortex and offer seizure control equivalent to standard approaches. This is the theory. And is there an improved neuropsychological outcome after preserving the neocortex and so-called functional brain? That we'll see in the subsequent quoting of literature. Significant memory loss, especially after left selective anterior amygdalohypocampectomy, may be problematic. I had one patient who had severe difficulty in naming his friends in his workload. A very high functioning individual and engineer who was doing very good work, but couldn't name his friends for nearly 6 months after undergoing selective amygdalohypocampectomy. The risk of undergoing selective amygdalohypocampectomy may outweigh the benefits if there is greater frequency of seizure recurrence coupled with similar neuropsychological outcomes when compared to ATL. So the issue is, if you have persistent seizures and you have similar neuropsychological deficits to ATL, then what is the point of doing a selective amygdalohypocampectomy? So this is a meta-analysis where 1,200 patients from 11 studies were taken, and it was shown that in this meta-analysis, statistically, it was more likely to achieve an Engel class 1 outcome after anterotemporal lobectomy compared with selective amygdalohypocampectomy. So now we come to pros and cons of ATL versus selective amygdalohypocampectomy. Anterotemporal lobectomy and amygdalohypocampectomy offered a significant advantage over selective amygdalohypocampectomy in patients with temporal lobe epilepsy when the goal of treatment was freedom from disabling seizures. So we have to define the goal. Most of our Indian patients, not all, but many, want seizures to stop. And they have pre-existing neuropsychological deficits which may not worsen significantly in the postoperative period to make a difference to their lives. So for them, the most important thing is seizure freedom after surgery and no possibility of doing a second surgery to give them seizure freedom. The advantage of doing an anterotemporal lobectomy is that the epileptogenic zone in mesial temporal lobe epilepsy is likely to extend beyond the confines of any lesion identified on MRI or histopathology. We believe strongly in electrocorticography, unlike what George said about his experience in Chitra. Dinesh Naik also qualified and worked in Chitra for a long time. And we use electrocorticography to do tailored resections when we do surgery on the temporal lobe and, of course, on the extratemporal lobe epilepsy. And RCT has demonstrated a correlation between greater extent of resection and class 1 outcomes after selective amygdalohypocampectomy. So the extent of resection, whether you do an anterotemporal lobectomy or a selective amygdalohypocampectomy, the extent of hippocampus and amygdala removal, parahippocampal gyrus removal has been shown to correlate with seizure freedom and class 1 Engel outcomes in many studies. it stands to reason that more extensive resections could explain improved results after anterotemporal lobectomy. But what about neuropsychological outcomes? There are very high functioning individuals. For example, you can have a patient with left temporal lobe epilepsy with normal memory, normal verbal memory, very high IQ, and removing a hippocampus completely in such a patient may give rise to a deficit, which may be very difficult for the patient to overcome and may hamper his day-to-day life. A review identified 20 articles that compared the neuropsychological outcomes and could not establish any clear superiority for selective amygdalohippocampectomy. So it's controversial. There has been a lot of to and fro. People arguing for selective, people arguing for anterotemporal lobectomies. RCT is showing one kind of finding and showing the exact opposite kind of findings. So in continuing the debate, ongoing seizures are an independent predictor of socioeconomic dissatisfaction, depression, and progressive cognitive impairment. So it's not a simple matter of doing reinvestigating and doing a second surgery. There are a lot of side effects associated with persistent seizures after first surgery, and they have all these problems. And patients undergoing anterotemporal lobectomy may take an initial cognitive hit. They may perform better in the long run because of cessation or even partial reversal of cognitive decline attributed to seizure remission. Continuing the debate further, complete seizure freedom from ATL may also provide additional benefits like avoiding a second operation, cessation of AEDs, and lesser incidence of SUDEP because of various reasons like mitigation of polypharmacy. This is a review article where cognitive outcomes of different surgical approaches in temporal lobe epilepsy was compared, and 44% of patients with verbal memory decline after left-sided surgery as compared to 20% after right-sided surgery. The role of seizure control for postoperative course of cognition is still a matter of debate. Long-term follow-up study indicated that further decline versus recovery depended upon seizure control. So what are the determinants of cognitive outcome after surgery? The first and most predictive factor is functionality of the brain area affected by epilepsy, which has to be resected. If you can show that the area of brain which requires resection, that is the ictal onset zone, is functional, then deficit is highly likely after surgery. And what is the mental reserve capacity? Mental reserve capacity concerns brain areas and functions not affected by epilepsy or surgery. So mental reserve capacity can help to compensate surgical defects. And seizure control is the third determinant of cognitive outcomes, release of functions due to control of epileptic dysfunction. So this is very important. Once epilepsy stops, the interictal epileptiform continuous discharges stop and the anticonvulsants are tapered or stopped, better still stop, then seizure control becomes a very important determinant of cognitive outcome. And the functional integrity of the affected tissue to be resected and reserve capacity are both reflected by baseline performance. Those with a better baseline performance are at a greater risk to lose cognitive functions after surgery, but these are the cohort of patients who also can recover from deficits well. So the cognitive outcome in the debate of selective amygdalohippocampectomy versus anterotemporal lobectomy, smaller as opposed to larger resections are associated with better cognitive outcome. This has been shown in many studies. And also, many studies demonstrated better cognitive outcome after selective surgery compared to a certain number of studies which showed no difference. So there is continuing controversy. Some studies showing better outcome with smaller resections and some studies showing no difference between smaller and bigger surgeries. So coming to selective amygdalohypocampectomy, it was already stated by Abhida there are 3-4 approaches which are done. The first one was described by Niemeyer in 1958, which is the transcortical middle temporal gyrus approach. Abhita showed Dr. Atul Goyal's modification in order to preserve the bundles in the roof of the temporal horn and the optic radiation, that Meyer's loop. Yasser described the approach through the superior temporal gyrus or through the inferior sulcus of the insula to reach the temporal horn. The subtemporal approach was described by Hori in 1993. These are certain advantages when compared to Transylvanian approach of Professor Yasser. You have the temporopolar approach where you resect a very small portion of the temporal pole and enter the temporal horn and do the surgery like any of the surgeries already shown. And then you have a direct approach to the medial aspect of the temporal lobe, which is called the supracerebellar, either infratentorial or transtentorial approach to the amygdala and the hippocampus, where you don't have to cut any of the covering neocortex and mesocortex of the temporal lobe. So in anterotemporal lobectomy, you remove 4 to 5 centimeters of the anterotemporal lobe along with the hippocampus. The hippocampus is removed till the posterior curve of the brainstem is seen. I look for this particular, you can't see the colliculi, but you can see the posterior bend of the brainstem. That is the tectal plate. And also the first branch or the largest branch of the posterior temporal artery supplied by the PCA is also serves as a landmark for the extent of removal of the hippocampus when you do it either as part of anterotemporal lobectomy or as part of selective amygdalohypocampectomy. And this pictorial representation of the middle temporal gyrus approach. The problem with the middle temporal gyrus approach is you may have to use retractors, and this may produce white matter and gray matter changes in the surrounding gyrus, including the temporal pole. And this has been shown in MRI studies that there is significant gliosis in the brain surrounding the MTG approach. So the different cognitive sequelae of using the type of surgery. When you do a left temporal lobe surgery, there is impaired verbal memory. Type of surgery, temporomesial, there is loss in long-term memory aspects of verbal learning and memory. When you do temporolateral, that's a lateral approach, there is loss in short-term and working memory aspects of verbal learning and memory in respect to, along with the long-term memory loss. And in neocortical lesionectomy, there is very little of neuropsychological changes seen unless you do directly on the speech area. So these are the various studies which shows the neuropsychological outcome after doing various types of surgery. In the interest of time, I'll skip this. And Transylvian, as Abhida told, Professor Yasser approach goes through the superior temporal gyrus and the temporal stem is cut, and also the fibers there, which include the inferior fronto-occipital fibers, they are cut. And there are no differences in learning and memory between the approaches. In the middle temporal gyrus, there is better post-operative recovery of executive functions. And in the subtemporal, it is not actually through the ITG, but it may be through the collateral sulcus and part of the fusiform gyrus to enter the temporal horn. And there are no disadvantages associated with the Transylvian approach. So in the Transylvian, as you can see in this slide, the temporal stem is cut. It is preserved in the middle temporal gyrus approach, as Dr. Abhida already told. It's preserved in the subtemporal approach, and it's preserved in the temporopolar approach. So the clinical and cognitive outcome in transfilian versus subtemporal. So the clinical is my slide C.
Yes, sir. Yes, sir. Yes, please go ahead.
Oh, suddenly I had a message saying, please restart your video. So you have this cognitive decline as shown here in subtemporal versus trans-Sylvian approach. One point of caution in the subtemporal approach is the basal temporal language areas, which has been described, and now a lot of importance is given to that, where basal language area is involved in lexical processing and effect on ITG and ventral stream. This ventral stream, visual perception, imaging, and memory can be affected. So going a little back, the issue in using selective approaches, the corticotomies are small, whether in the superior temporal gyrus, whether in the middle temporal gyrus, or through the collateral sulcus and the inferior temporal gyrus. They are not very large corticotomies, and taking into account like various venous and arterial patterns on the surface of the brain, they have to be magnified using navigation to give optimum exposure of the ventricle. So no single surgical approach is safest with regards to cognition, irrespective of seizure control. And different tissues and fiber tracts hinder surgical procedures, which have consequences for cognition. But in our patients, especially, does memory impairment matter? It may not be clear whether subtle differences in memory outcome, which are assessed using sophisticated tests in a laboratory, have any relevance for the patient who wants foremost to become seizure-free. Patients are in part willing to risk some cognitive decline in order to become seizure-free. And we refer to patients who continue to have seizures with neuropsychological deficits or any other deficits as double losers, who in the long run do not become seizure-free and in addition experience significant memory decline. So in our series of 479 patients, this tally was done till August 2024. We had only 6 selective amygdalohypocampectomies. I used the subtemporal approach in 3 and the tempopolar or tailored approach in another 3. Started as selective, but had to modify it into a tailored resection. So 3 patients who started as selective amygdalohypocampectomies were converted to tailored and tailored resections. So reason for the low number of selective procedures had already been alluded to by Dr. George. They are red flags in semiology of temporal plus insula, which is so-called insula trap, neocortical involvement either shown by MRI or PET or even video EEG when you have the middle and the posterior temporal chain getting more involved than the anterior temporal chain, temporal pole involved in the MRI, red flags in video EEG, where the spikes, the interictal spikes are seen in the suprasylvian electrode contacts on the scalp, and neocortical spiking in electrocorticography. So we use all these red flags and treat them very seriously. And any of these parameters, when they are present, we don't offer the patient a selective procedure. So the criteria for selecting patients for selective amygdalohypocampectomy is the semiology criteria. Patients have febrile seizure, a honeymoon period followed by typical aura of either rising epigastric aura, for example, behavioral arrest, automatisms, and no secondary generalization. Interictal, as I mentioned before, antetemporal spikes, no mid-temporal or posterior temporal spikes, no suprasylvian spikes. Ictal pattern should be type 1A Ebersol confined to the temporal chain, a rhythmic temporal theta without involvement of the parasagittal chain. So these all indicate that the seizures are there outside the temporal lobe. MRI shows hippocampus involved with no neocortical or temporal pole involvement. PET shows mesiobasal temporal hypometabolism. Neuropsychology shows well-preserved, high-functioning person. And electrocorticography show no neocortical spikes at the end of selective resection. You can have some neocortical spiking before the hippocampus is removed, but the complete disappearance of neocortical spikes at the end of a selective resection, we again use that as a criteria for saying we can stop with the selective amygdalohippocampectomy. So I want to show a few cases. A 29-year-old male with clinical diagnosis of CPS left temporal. So you see the shrunken left hippocampus. The neocortex appears normal when compared to both the sides. And PET scan shows mesial temporal hypometabolism. This patient's video EEG showed that only the antetemporal chain was involved in the seizure ictal onset and propagation. There was no secondary generalization. So a subtemporal approach was used. This is the positioning of the patient on the table, where we use the gravity to do temporal lobe retraction. In subtemporal approach, the temporal lobe can be retracted significantly. So one has to be very cautious regarding that. Also, the place where the vein of Labe tethers the temporal lobe to the middle cranial fossa base, if it's very anterior, again using a subtemporal approach becomes impossible. So this is the post-op scan showing a selective resection of the amygdala and the hippocampus with preservation of the temporal pole, the lateral neocortex. And this patient is an engineer. He had severe anomia post-op, which lasted for 6 months. But fortunately for us, it resolved and is gainfully employed. He has been under follow-up for 11 years, 7 months. And he has a very good outcome of Engel class 1. There's another patient who got married after undergoing a selective amygdalohippocampectomy. So doing epilepsy surgery, the idea is there is physical, mental, social, and economic integration of the patient, and there is no burden of normalcy. When you have patients with very long duration of seizures, you can potentially have patients who are suddenly normal now and expected to do everything, and they develop so-called burden of normalcy in such a scenario. And when you do selective amygdalohippocampectomy, you should be very careful about double losers also, because you can have seizures with some neuropsychological deficit after surgery. So family support, counseling, and rehabilitation is very important for these patients. The second case is a 37-year-old female with intractable temporal lobe epilepsy. Video EEG showed 9 CPS, typically left temporal. And this is the MRI picture showing hippocampal sclerosis, and the PET showing selective medial hypometabolism with normal neocortical hypometabolism. And this patient underwent a temporopolar approach with corticography. When you approach through a selective amygdalohippocampectomy approach, always the approach is perpendicular to the surface of the brain. So when you use a Transylvian approach, again through the superior temporal gyrus or through the inferior sulcus of the insula, you have to go perpendicular to the surface of the brain to reach the ventricle. An oblique approach will disorient you and take you away from the temporal horn. Similarly, in the middle temporal gyrus, it's exactly perpendicular to the surface of the brain to reach the temporal horn. The difficulty is in the subtemporal approach, where doing a perpendicular approach to the surface of the brain becomes difficult. And it's here where intraoperative navigation is of maximum help to orient your incision and reach the ventricle through the collateral sulcus or the fusiform gyrus or the inferior temporal gyrus. So this is the temporal pole approach, where the temporal pole has been removed. 1.5 to 2 centimeters of the temporal pole has been removed. and then the hippocampus exposed. This is the amygdala, hippocampus in the floor of the ventricle. And then this is a point which I wanted to make here. The pia arachnoid was adherent to the brain, and while removing that, the anterocoroidal and the branches got exposed. Here one should never use bipolar artery, and suction should be at a very low setting so that these vessels don't get sucked into the suction and cause anterocoroidal artery damage. And the amygdala is resected till you see the optic tract. This is the ICA and the MCA. And then the hippocampus is exposed. Dr. Hari showed excellent videos on the way to mobilize the hippocampus. And then after excision of the hippocampus, you see the PCA, the third nerve, the anterior surface of the brainstem, the posterior surface of the brainstem. We saw the optic tract earlier in the roof of the, near the roof of the third ventricle. So if I go back, this optic tract is the upper limit of the resection of the amygdala, because above this is the lower pole of the globus pallidus interna. One should never go above this in resecting the amygdala. So it's always a partial or a subtotal resection of the amygdala. And this is the post-op scan showing resection, relatively selective amygdala hippocampectomy. Here I've done a temporal polar approach. So this can be correctly classified as a tailored resection, though not ECOG guided. For doing the resection, after doing the resection, the ECOG showed there were no neocortical or temporal subtemporal spikes, which resulted in stoppage of the surgery at this stage. So 7 years follow-up, seizure-free, Engel class 1 outcome. So these are the 6 patients who underwent in our series of 201 temporal lobar surgeries in the series. I showed this case 1, subtemporal approach. Then there were 2 others who underwent selective amygdala hippocampectomy. I showed a photograph of this lady getting married, and the other 3 were started as subtemporal approaches and converted to either tailored ATL or polectomy and ATL or ITG tailored resection, because corticography showed the extensive spiking from the neocortex. So this is the number. And because of the strict selection criteria, where we eliminate temporal plus, insular epilepsies, outer temporal lobe surgery, we had a good outcome in 91% of patients. However, I have to emphasize that even after 5 years or 10 years, they can have a very severe recurrence in occasional patient. So long-term outcome is the norm to tell that the patient is cured of epilepsy, temporal lobe epilepsy. So the complications and avoidance of selective amygdalohippocamectomy, a visual field defect can be avoided either by a middle temporal gyrus approach or a subtemporal approach, as already shown. Vascular injury is more likely in transfilian approaches, so very precise microsurgical approach, dissecting the sylvian fissure and recognizing the first anterotemporal branch of the NCA, and the approach is behind that first anterotemporal branch of the MCA is important. And like I showed, preserving the pia arachnoid cover mesially is very important. Sometimes it may go, but even then, avoiding bipolar coagulation, as Dr. Arivalagan so very elegantly showed the subpile dissection. So avoiding bipolar coagulation completely in the mesial temporal region is the key to avoid anterocoroidal artery injury. The middle temporal gyrus and the subtemporal gyrus approaches are most prone to gray and white matter damage. When you do an MRI, both immediately or during follow-up, you see that there is gray and white matter damage due to the retraction. And very gentle retraction or no retraction is preferable. Sometimes it's easier said than done. You have to use the retractor as a tool to retain the brain rather than retracting the brain for visualization of the hippocampus and the amygdala through a small corticotomy. Memory loss in very high functioning individuals, sparing part of the hippocampus may be a strategy. Sparing the temporal stem is also said to result. Cutting the temporal stem has a high incidence of seizure freedom after surgery. At the same time, the memory loss which occurs in antetemporal lobectomy, part of it has been attributed to cutting the temporal stem and the fibers in the roof of the temporal horn. So sparing them using modifications of Professor Yasagil's approach or Professor Atul Goel's approach, MTG, or the subtemporal approach can spare the temporal stem. Neuropsychological deficits, no approach is 100% safe, but deficits may not be clinically relevant for many patients. They may already have long-standing neuropsychological deficits. They may be used to that, and there may be no significant worsening of doing surgery in such patients. However, when you have an intact, high-functioning individual, a lot of thought has to go into what kind of surgery the patient requires. So this is what I was talking about when there is retraction of the brain. White matter change consistent with gliosis was demonstrated in the antetemporal lobe to a mean distance of 4.5 centimeters after transcortical, that is the MTG approach, and to a lesser degree as a consequence of transsylvian amygdalohypocampectomy. There is more secondary damage to the temporal lobe after amygdalohypocampectomy than was previously recognized. So here comes the question, how selective is a selective amygdalohypocampectomy? 53% of patients demonstrated Wallerian degeneration in the optic radiations after surgery. All had incomplete contralateral quadrantinopia. In fact, so much so that it is taken as part of surgery when doing antetemporal lobectomy. However, there are strategies, as already enumerated, to spare the Meyer's loop and avoid a contralateral quadrantinopia. There is evidence that individually tailored and standard selective approaches have a superior functional outcome compared to extended standard anterior temporal lobectomy. Even with selective approaches, collateral gray and white matter damage should be considered and kept in mind, and appropriate care taken during surgery to prevent this damage. Whether cognitive losses can be further reduced by super selective treatments such as radiosurgery, deep brain stimulation, laser, MR-guided focused ultrasound is a matter of debate and also developing experience with these techniques. As Dr. George very correctly told, this is a very large target. Temporal lobe epilepsy is a very large target, and doing a small lesion there, whether it's going to result in seizure freedom or will result in recurrence. All these techniques are known to result in recurrences requiring reoperation, sometimes several times. So subtemporal selective amygdalohypocampectomy provides favorable surgical and neurosurgical outcomes and does not cause significant postoperative decline of verbal memory performed on the language dominant side. In Transylvian selective amygdalohypocampectomy approach, the anterior part of the temporal stem containing all temporal fiber collections, including uncinate fasciculus, is transected, considered important for achievement of freedom from seizures. My time is up, I think, no?
Yeah, we are exceeding time, sir.
Okay. So in conclusion, a strict selection criteria for doing selective amygdalohypocampectomy is required. And at least I've seen in our series, that is what limits the application of selective amygdalohypocampectomy. Subtemporal approach or a middle temporal gyrus approach spares vision better and is also better for memory preservation. Selective approach may not be so selective if there is collateral brain damage due to the approach. Thank you.
Thank you, Ravi Rao, sir. I'll just, I think we have exceeded time. I have to call Malla Bhaskar Rao, sir, for giving concluding remarks. We may not have time for any elaborate discussion. Sir is former professor and head of the department at NIMHANS, Bangalore. He was also uh, additional professor in Srijitra. Directly or indirectly, he is the teacher for almost all epilepsy surgeons in the country. His work has been pioneering, and the way it evolved in Chitra is remarkable. And the rest of the history of epilepsy surgery in the country is well known to everybody. I call upon Malla Bhaskar Rao sir to give his comments on the webinar.
Dr. Matthew, can you see me?
Sir, I can see you.
Yeah, I think there is some screen on my computer. Anyway, that's fine, no problem. So thanks to Matthew and NSI Webinar Committee for the opportunity. I followed the webinar with great interest. It's very, very informative and very, very interesting. Congratulations to all the speakers for the excellent work and presentations. For the benefit of 60, 70 participants, and of course, it will be on the NSI archives subsequently. Just a few very brief comments. First, regarding the patients, we have hundreds and thousands of people with temporal lobe epilepsy. These people, unfortunately, only 1 in 1,000 is getting an opportunity to undergo pre-surgical evaluation as well as surgery, and that too after waiting for more than nearly 2 decades. Something has to be done for that. That is number one. The number two, regarding doctors, we have more than I think 3,000 neurosurgeons in India. Only 100 or even less than 100 neurosurgeons ever get an opportunity to operate on the hippocampus during their career. Maybe the training during MCH and national board programs is limited, and there are not many fellowships in epilepsy surgery following MCH and DNB. So that has to be addressed, and very little research is being done in epilepsy surgery, especially regarding the surgical specimens, which are like gold mine. So to address all these three issues needs a collective effort. The national institutions and even non-formal teaching institutions all have to work together, public, private partnership, to improve the service. CSR activities, philanthropy. In fact, every medical college, hospital in India, every neurosurgical center where microsurgery is being done, I think should have an option to have a basic epilepsy surgery at least. And these programs, especially epilepsy surgery programs, have to be subsidized, have to be funded. And regarding training, I think it has to be functional, and epilepsy surgery has to be included in the curriculum. There should be wherever feasible, like medical college institutions where there are anatomy labs, should have the neurosurgeon should use cadaveric workshops, and there should be those who are young neurosurgeons who are aspiring to do epilepsy surgery should go for either short or long-term visiting fellowships. And as a incoming president of the Indian Epilepsy Society, I'll be very happy to facilitate these training programs across India in the near future. And my last point is regarding research. In the last 25 years, we have done 15,000 epilepsy surgeries. During the same period, Europe has done 15,000 epilepsy surgeries. But all the 15,000 epilepsy surgery specimens were preserved in uh, uh, epilepsy brain bank in Germany. you see, this FCD classification has been revised, and regarding Schizer medication, Schizer outcome studies, a lot of data is being generated by the European Epilepsy Brain Bank. In our country, except institutions like NIMHANS, AIMS, and Sri Chitra, in other centers, the specimens after diagnosis probably they're not preserved and no research is being done. So I hope these issues will be considered by all the young people, and hopefully some of the participants will take up epilepsy surgery as their career in the future. With that brief comments, I will end my. Thank you. Thank you. Dr. Matthew, you're muted.
Yes, true. Thank you, sir. Thank you so much, sir, for being an expert panel. And hope your wishes will come true, and epilepsy surgery will become a popular specialty and will solve the problems of virtually millions of patients with MTS in our country. I don't think we have time for any detailed discussion. Since we have exceeded time by almost 25 minutes, we will. I'd like to thank all the speakers, the panelists, and my co-moderators for such a lively and wonderful session. The participation exceeded 75, closing on to 80. And thanks once again. And hopefully it will become a motivation for our youngsters to take up this specialty. Thank you so much.
Thank you. Thank you.
Thank you, sir.
Thank you.
Thank you, George. Thank you, Hari.
Thank you. Thank
Thank
you,
you.
everyone.
Thank you.
Thank you, sir. Good night.
Thank you,
Thank you.
Some
Bhaskar.
of the questions
you.
have been answered in the chat box. I hope that was there were a lot
Yeah,
of
yeah.
questions in the chat box. So
Yeah.
we were doing like writing the exam last 2 minutes. We are trying to answer all the. We kept it for
Yeah, I
the
could see.
since we had to give the due time to Dr. Ballabhaskar Rao. So me and Jar just trying to complete the question paper. We are doing the last minute answering. I hope it helped. Thank
I
you.
must have taken only few seconds, Hari.
No, sir, we thought we will have some time, but we didn't. So it's like we went back to our student days. We were like last minute answering the last question, completing the paper. Thank you very much.
Okay, thank you so much.
Thank you.
Thank you.
Good. There were
Thank
some
you, sir. Thank you.
international participants also today, I could see.
Yeah. This was very well attended.
Yeah.
Okay.
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 Thank you.
Thank you. Thank you so
Have a
much.
good
Thank you. Thank you.
Yeah.
Bye.